Hi, everyone. Thanks for tuning in. My name is Megan. I am one of the occupational therapists in the outpatient care center over in 2C. So, when this is all over with, come on by and visit. Thanks for tuning in. I know this isn't necessarily the ideal way to be listening to lectures and everything, but hopefully, this will work out pretty well. I'm going to send you guys this PowerPoint and this video so you can speed it up, watch it at your own time. My husband is in PA school right now, so he's been doing a lot of online lectures too. And he really likes using VLC so he can speed it up and get through the lecture a little bit faster. So hopefully you guys have found some ways that work best for you. But let me introduce myself before we get started. So, like I said, I am one of the occupational therapists. I am a hand therapist, and I've been at UIC for about 3 years now, practicing OT for 7, most of that time in hand therapy. Right now, I am actually, everyone's being flexible. I am working on the inpatient side of things, either as a therapist or a CNA on one of the COVID units. Just, it's healthcare. We got to pitch in, and everyone does what they can. So, hopefully, this will be informative for you. You are more than welcome to reach out to me at any time with questions or concerns. You can email me, you can call me. I'll make sure that you guys have my information so that we can make sure that this is the best experience possible for you guys. So today what we're going to be doing is doing a big overview of hand and wrist kinesiology, and I'm going to try to incorporate that with some information on pathology and different conditions that you might see, different assessment techniques, and interventions. So because this is your second year, you've already gone through a lot of the coursework on the anatomy and kinesiology, and you guys should be pretty familiar with that. So I'm going to try to breeze through a lot of it, but give you a little bit of an overview, and maybe for some things go a little bit more in depth than you typically do for some of these things. So if you're getting bored, you can always zoom through it, or you can re-listen. Something that I wanted to point out is that hand therapists talk a lot about abbreviations, so it takes some time to get used to some of these things. But when you're using these words all the time and you're trying to say, flexor digitorum profundus, extensor digitorum communis, those are a mouthful. So we use a lot of abbreviations. So in the PowerPoint that I send you, it should include the note section, which I don't typically do. But since we're doing this online, I figured that would be a good way for you guys to still have some of this information recorded somewhere, so it might be a little bit easier for you guys to study. Something else that's pretty important to go over is, I think, the language that we use to talk about hand and wrist and everything. There's a lot of different terminology out there, and it can get confusing if you're kind of speaking a different language, especially with the surgeons. So for clarity, in our lecture, I'm going to use the abbreviations IF for index finger, MF for middle finger, RF for ring finger, and SF for small finger. Some people might use a numbering classification, so digit 1, 2, 3, 4, but then there's always confusion. Is the thumb a digit? Is it different because it has different anatomy and different muscles? So I like my classification of IF, MF, RF, SF, but you might see different things in the literature. So one thing that I also wanted to talk about is kind of what is hand therapy? Why is OT up here talking to you guys today? Hand therapy, I think, is one of the coolest areas of rehab because you can be a certified hand therapist and be a physical therapist or an occupational therapist. It's one of the few specialty certifications that you can have either discipline, sit for, and take this exam. It's a pretty rigorous test. To qualify to sit for the exam, you have to have 3 years of practice in hand therapy. You have to have 4,000 hours of dedicated upper limb experience. So you have to fill out a bunch of forms that your managers have to sign to verify that, yes, you do work there, and yes, this is the population you treat, and stuff like that. And then you have to pass the exam. Last November, it was about a 55% pass rate, so not great. But it just shows that there's a lot of extra education that goes into hand therapy. So I don't mean to say this to sound like, you have to study a ton and this lecture is going to be really scary, but just to introduce you to the fact that, there's a lot of things that we won't cover, and that's okay. I think for most specialties in therapy, we want you to get the basics down so that when you're out there treating, if someone walks in the clinic with a distal radius fracture, you're not like, I don't know, I'm not a hand therapist, I can't treat that. Yes, you can. Every PT can treat that. Don't let anyone say you're not a hand therapist, so you can't handle the basics. On the other hand, though, pun not intended, there are some things that really should be sent to just a hand therapist. I can't tell you guys how many times that I've seen really delicate surgical procedures that have been kind of destroyed by not great therapy. So some things like nerve repairs, especially flexor tendon repairs, those are the big ones. You know, some people might think, oh, your fingers aren't moving because they're weak, so why don't we strengthen them? And then you snap tendons and they have to go back for surgery. So one thing that's really important to do with that is know what's in your skill set and what things you need to reach out for help for. Your best partner in hand therapy is going to be the hand surgeons that you work with. So you have to be really comfortable talking to them about certain things like what repair technique did they use, what are the precautions, what is safe to progress this patient through. There are some protocols. You'll hear a lot about the Indiana protocol books. Those are general. They're really, really helpful, but they shouldn't be taken literally for every single patient that you see. So you really have to be comfortable talking to your surgeons and know that they're not therapists. They don't know what you do. So don't be afraid to ask them a question. I think they really appreciate having therapists talk to them and collaborate with you instead of just, we don't just follow orders. We get to use our clinical judgment, and I think they appreciate hearing from us. So some precautions that you might see are like passive range of motion, only in deflection with active extension, or move certain joints only to this degree, things like that. So you just want to check and make sure that you kind of know what you're going for. The nice thing with both hand surgery and hand therapy, they're newer specialties in the scope of medicine. Both were actually the hand surgery certification with the boards. That was just that was created in the same year that the hand therapy certification exam was created. It was 89, so really pretty recently. Most hand surgeons have a background in either orthopedic surgery, which makes sense, or plastic surgery because of their strong emphasis on microvascular repairs. So it's kind of a nice combination. Like, we're all pretty new in this. A lot of our professional organizations are newer. So people want to work with you and people want to collaborate. So it's a really nice world to be in. Okay, so now we're going to get started talking about some of the fun stuff here. So we're going to go through the basics first in the nerve and vascular supply of the hand and wrist. So these are things that you guys know so well, but we'll go over a little bit of it. So the median nerve they call it the $1 million nerve because it controls most of the important muscles in your thumb, not all of them, but they call it the $1 million nerve because theoretically, if you're injured at work and you can't use your median nerve anymore, it's an easy $1 million settlement. Things to note, the median nerve, as it dives deep in the forearm, it becomes the anterior interosseous nerve to supply a lot of the motor components. So you might see anterior interosseous nerve written. That's what that's for. In addition to the majority of the thenar muscles in the hand, the median nerve also innervates the radial two lumbricals for the index and middle finger. Higher up in the forearm, the median nerve is controlled. The median nerve innervates some of the long flexors, mostly the radial-sided flexors. The ulnar nerve innervates some of the flexors too, the ulnar side, and some of the ulnar wrist flexors. It also comes in and kind of swoops up the ulnar side of the hand to innervate all of the interosseous muscles. So the palmar and dorsal interosseous muscles that control ab and adduction of the digits. It controls the ulnar two lumbrical muscles, as well as the hypothenar muscles, the adductor pollicis, and the deep head of the FPB muscle. So that's kind of a trick thing you'll see thrown into a lot of exams, the adductor pollicis, even though it's some people will call it a thenar muscle, it's technically not in the thenar compartment because it's ulnar nerve innervated and it's a little bit deeper. So that's something when we talk about nerve injuries in a little bit, you'll see how that plays off, that there's two different nerves that might control the function of the thumb. The radial nerve is the nerve on the dorsal aspect of the forearm and hand, so it innervates all the extensors. As it dives down into the forearm, you'll see it called the posterior interosseous nerve as well. So that just tells you a little bit about the location of it. In the comment or in the notes section of this slide, there's an article that I'll make sure that Rich gets so you guys have access to it. This is one of the best articles on entrapment of the upper quarter that I've ever read. It does such a nice job of breaking it down. But something that's really interesting and really important to note that's from this article is the comment written just above that each of these three nerves enters the forearm by diving down and piercing the two heads of a specific muscle. So the median nerve enters the forearm through the heads of the pronator teres, which means that if the pronator teres is getting overworked, you can have median nerve compression. The ulnar nerve enters through the two heads of the FCU muscle. So if you're doing a lot of wrist flexion and ulnar deviation and that muscle is getting irritated, you can have ulnar nerve compression. The radial nerve pierces and dives down between the two heads of the supinator. So if you're doing a lot of forearm rotation, you can have radial nerve irritation at that point. So every discussion with nerves should also talk about the cutaneous innervation. This is really important. We're going to kind of split it up into two parts and talk about the peripheral nerves now and the dermatomes on the next slide. You'll get a lot of weird referrals that just say hand numbness. And there are some people that, a lot of therapists will just look distally and say, oh, your thumb is numb. Okay, that must be, if you look at these charts, okay, that could be the median nerve. It's carpal tunnel, that's it. But don't forget about your dermatomes. So you always want to look more proximally and see what else is going on. In general, in the hand though, the median nerve is going to control the sensation to your thumb, the radial side of the palm, the palmar index and middle fingers, and the radial half of the ring finger. And it's crazy in people with carpal tunnel, it is only half the finger usually. The ulnar nerve controls the other half of that ring finger, so the ulnar aspect of the ring finger, and then the small finger, both volar and dorsal. So the ulnar nerve kind of wraps around to come on both the palmar and dorsal aspects of the hand. The radial nerve, it's on this slide in red on the right side, that controls the dorsum of the hand, but that median nerve comes up and wraps around just the tips of the fingers. So you can see it's a little bit purpley there. The median nerve does come back to about the proximal or the middle phalanx or the distal phalanx, and then the radial nerve takes over for the hand. So here's where we talk about dermatomes. So if I am telling you my thumb is numb, it could be median nerve dysfunction, but it could also indicate that something's going on in C6. So when we're talking about hand and wrist problems, we're primarily focused on C6, 7, and 8. So again, your patient with hand numbness, you have to look central. In every hand therapy evaluation, we always want to at least screen out proximal issues to make sure that we're catching the whole picture of what's going on. Even if there is a distal problem, there might still be a proximal issue as well. In something like double crush syndrome, where there is nerve compression at one part, and then because the axoplasmic flow of the nerve is altered, it's really easy to get compression somewhere else. So if we're only treating for maybe we think it's cubital tunnel at the elbow, let's say, but we're missing that there's an elevated first rib, and we keep working on everything in the elbow and it's just not getting better, it might be because we missed it and we're only treating half that nerve. So just make sure whenever you're looking at something distal, always go back and screen out proximal too, and you might want to treat there as well. So let's talk about one of the biggest bread and butter things in hand therapy, the carpal tunnel. So the carpal tunnel, you hear people say, oh, I got carpal tunnel. Carpal tunnel is really referring to the anatomical location in the body. The carpal tunnel is made up of the carpal bones covered by the flexor retinaculum. So just make sure you're saying you have carpal tunnel syndrome, not carpal tunnel, because we all have carpal tunnels. So the carpal tunnel is an important region because it contains all the FDS, the FDP tendons, as well as the FPL. So there's 9 tendons overall and the nerve. So what happens, you can see in this drawing where it shows all the tendons in there, there's not a ton of space in there. So if the tendons are being overused or you're constantly flexing your wrist and having that repetitive or sustained flexion, the tendons in the tendon sheath is really what kind of gets inflamed and irritated. They don't have anywhere to push. They can't push on the flexor retinaculum because that's pretty thick. That's pretty strong. And they're not strong enough to push on the bones either. So the only space it has to expand is to expand and compress that nerve. So that's where you get carpal tunnel syndrome coming from. So in carpal tunnel syndrome, like I said, this is happening because the flexor tendons are irritated and they don't really have anywhere to go or expand, so they start pushing on the nerve. What you'll have in patients with carpal tunnel syndrome is they'll report that either there's pain or paresthesia, so it might just be numbness. It doesn't necessarily have to be pain in their thumb, index finger, middle finger, and the radial half of the ring finger, which is pretty cool to see exactly how that nerve innervates just half of the finger at once. Sometimes if it progresses, you'll see weakness or atrophy of typically the thenar muscles in the hand, so it almost kind of looks like a little divot in there. That's when carpal tunnel is pretty severe and usually going on for a longer time. When you're evaluating a patient that comes in with suspected carpal tunnel syndrome, you really want to make sure that you're differentiating between any nerve compression higher up. So the median nerve is composed of most of the brachial plexus roots, so it's C5 to T1, and it could be damaged to any one of those parts. Typically more the higher levels, C5 and C6, have the greatest contributions to the median nerve, but it could also be an issue with the brachial plexus, usually the medial or lateral cords. And another common thing is pronator syndrome. So it's really easy to confuse pronator syndrome with carpal tunnel syndrome. In pronator syndrome, like we talked about before, because the median nerve dives through the pronator teres as it enters the forearm, if the pronator teres muscle becomes irritated or inflamed at all, it can cause compression of the median nerve. So if the nerve is irritated higher up, what you'll have is paresthesia in the palm as well. When you think about the median nerve going through the carpal tunnel, it doesn't supply any of the cutaneous part of the palm. That part branches off actually a little bit proximal to the carpal tunnel. So because it goes over that flexor retinaculum, the cutaneous branch of the palm is not going to be impacted at all. So if your patient comes in and they're telling you, yeah, the doctor said I have carpal tunnel syndrome, my palm is numb, you know that's probably not carpal tunnel syndrome. It could be pronator syndrome. It could be something else more proximal too, but that's going to be one big indicator. Another way to differentiate pronator syndrome and carpal tunnel syndrome is the timing of their symptoms. So carpal tunnel syndrome is really common to have at night because a lot of people, when they sleep, they curl up into a position of comfort, which is typically in wrist flexion. So they might be sustained wrist flexion, which is going to compress the whole carpal tunnel, including the median nerve, for about 8 hours at a time. In pronator syndrome, because it's about muscle tightness and muscle compression, usually that happens during the day with activities, specifically in forearm rotation, and it could be supination or pronation, because when you're supinating, your pronators are stretched to their max length. When you're pronated, your pronators contract and get tighter, so it could be compressed in either direction, but typically happens with forearm rotation during the day. Carpal tunnel syndrome, again, at night. So if you have night numbness in your fingertips, probably more likely to be carpal tunnel. If you have daytime numbness in your palm, pronator syndrome. Carpal tunnel, though, is pretty common, where pronator syndrome is a little bit more rare. Carpal tunnel syndrome could occur in, there's huge variety of numbers, but like 3 to 10% of the population in the US. Some patients will get referred to therapy. In some cases, the surgeon will do an EMG or look at the hand and say, you know what, I see a ton of atrophy. We are going to do a corticosteroid injection directly into the carpal tunnel, or they might go for surgery right away. If you see them conservatively for therapy, the single most effective intervention is to immobilize the wrist, typically in neutral. You'll see some people propping it up in a little bit of extension, but that's going to stretch the median nerve. Flexion is going to compress the median nerve, so it seems like neutral is the way everyone's kind of agreed on. You can make a custom orthotic in the clinic if you feel like that's appropriate for this patient, or encourage them to look at any store with a pharmacy section really will have braces like the one in the photo here. They're pretty cheap and they're pretty durable, so you can wear them for a long time. The recommendations for wearing vary vastly because it depends on what the patient's doing. If they only have symptoms at night, only wear it at night. I have a friend that has carpal tunnel syndrome that says he's been wearing his splints for like 16 years and he's fine. He's not going to have surgery. He doesn't want to have injections. He's fine with it just wearing the splints at night. There might be some people that doesn't work for, and depending on their job or their activity demands during the day, they also need to wear splints during the daytime as well. So that's okay, whatever your patient needs. Carpal tunnel syndrome is often coming up because of activity demands and changes. So other interventions that you can do as a therapist, you really want to work on core and more proximal strengthening and control to make sure that their posture is good as they're doing these activities and they're not compensating for maybe scapular weakness by using more wrist flexion. You want to look at their activities. So maybe if they're typing a lot is probably the most common one that you'll see. You want to look at the ergonomic setup of their workstation and make sure that they know, okay, you want to keep your wrist in neutral, you don't want to be slumped over your keyboard, things like that. Tendon gliding is really important, so we're going to go over that in the next slide. Neurodynamic glides, which I'm sure if you guys haven't talked about them yet in school, you probably will talk about neurodynamic gliding at some point to make sure that the mobility of the median nerve is moving well, and maybe talk about pain management strategies for how to deal with this pain. So these exercises are called tendon gliding, and I wanted to put them in the start of this presentation because these exercises come up frequently throughout a lot of things in hand therapy. Tendon glides, the purpose of these exercises is to encourage differential gliding of the tendon surfaces on each other and to provide maximal excursion throughout these tendons. So when we're talking about flexor tendon gliding, we're talking about the FDP and the FDS. So these are the 5 standard positions. The important part is that you're moving into each position, not how much strength did you use to squeeze in each or how long did you hold it for. It's more about the motion. So you can move purposefully and deliberately, but you don't have to speed through them or you don't have to crawl. Just take it at your own time and pace. Between each of these positions, it's important to return to fully open as well to kind of reset everything. So in the open position, that's your full stretch of your FDS and FDP muscles. In position 2, that's the hook position. In the hook position, that's the maximal differential glide. So what that means is the FDS is moving as far away as it can from the FDP. There's a 14 millimeter difference in glide there. So we'll go from hook back to open. Then if we go to a full fist, that's the maximal motion of your FDP. So it moves 32 millimeters from its starting position. So it's a decent amount. Then go back to open. Your tabletop position is for your lumbricals, so that's your intrinsic plus position with MCP flexion and IP extension. Then come back to open, and then the flat fist is your maximal FDS glide. So that moves the FDS 26 millimeters in this position. From the research that I've seen, it doesn't seem like it matters what order the positions go. You can do open, full, open, hook, open, flat, open, table. You can mix it up and change it up. As long as you're getting each position, that's okay. I think it doesn't matter what order you go in because you're always returning to open between each. So you're kind of resetting between each one. Okay, so now we're going to talk about if your conservative management did not work. They tried injections, they tried wearing the orthotics, they've been trying ergonomic changes, they've been doing everything, and it didn't work. So now they're coming to you and they're really nervous. They're going to have surgery. So what I would do as a therapist, look up these videos. If you can, go into surgery and actually observe. I think number one, it's fascinating, but number two, lets you have a better idea of when your patient's going to have surgery. You can kind of talk to them about a little bit. You obviously want to let the surgeon do most of the talking about what they're actually going to do, and precautions and things like that. But for us to be able to know exactly what happens during surgery is really important to know how do we help in the rehab of that. So in the surgery that I was really fortunate to observe at UIH, it took 12 minutes from open to close. It was so fast. You can do an open release or a laparoscopic release. It's really pretty quick either way. There's standard risks for every surgery, like infection and wound closure and things like that. But because they're not actually repairing anything in these surgeries, what they're doing is they're releasing the flexor retinaculum. So they're going in, they're cutting a ligament, and they're sewing it back up. Because they're not sewing together a ligament or putting in something to an unstable structure, there's really minimal precautions that you have to worry about. So people can move really soon, they can start strengthening really soon, and they'll be back to work really soon. So a lot of these patients have great outcomes. It can come back. So there's some research in between 3 and 20% of patients it can come back, whether that's from scarring down or an incomplete release. We don't exactly know. So 12% of the reoccurrences end up going on for a second release, but for most people, they do really well. So every clinic is going to have some different standards and different ways that they decide who needs therapy and who doesn't. In some clinics that I've worked in, every single patient has hand therapy, and the hand therapist is the one that manages most of the post-op visits and everything. In other clinics, they only send people to therapy when they have complications, and the surgeon or someone else in the medical office will give exercises. So I'm going to share with you the protocol that of all the places that I've worked. This is my favorite. After surgery, 3 to 5 days post-op, they come in for an evaluation. So we take down all the post-op dressings. Usually there's a bulky plaster cast held on by an ACE bandage. So we take that off. They'll have a couple stitches, maybe 3 or 4. So you want to educate them on wound care and make sure they know what to look for in case of an infection. You want to start giving them active range of motion for the fingers and wrist, including those tendon glides that we just went over. And they can walk out with just a Band-Aid on if that'll cover it. They can have a little gauze wrap. You don't have to put anything special on it in most cases. If there's a problem with wound closure or something, talk to your surgeon, but typically they're pretty good. You might want to talk about edema too if that's an issue. But it because this is such a small incision, it tends to not be an issue, but something to look at. So then after that first visit, I'd see them a week later, and at that time, we'd be about 2 weeks out. So I would remove the sutures, educate on scar mobilization to make sure that the scar doesn't kind of grow those roots down and start adhering to the tendons and the nerve that we were just trying to free up, and continue with active range of motion. Visit 3, so now we're at about 3 weeks post-op, start them on some strengthening and discharge. So it's pretty easy. So if someone's nervous about having a carpal tunnel release, obviously the first person they should talk to is the surgeon, but you can kind of help to reassure them that, it's not going to be months and months of therapy or anything like that. So now we're going to talk about another common nerve injury in the hand. This is ulnar nerve compression or injury at Guillen's Canal. So Guillen's Canal is a location right by the hook of the hamate where the ulnar nerve passes through, and it's pretty commonly injured because of the hook of the hamate. This is also sometimes called ulnar tunnel syndrome. This will affect the palmar surface of the hand and the intrinsic. So it has both motor and sensory components depending on exactly where the nerve is injured. If it's injured a little bit more distal, it might be less sensory issues and more motor, or if it's injured a little bit proximally within Guillen's canal, you might have both effects. This can lead to clawing and interosseous wasting. So the top picture is a pretty typical presentation for clawing, but that could also occur with cubital tunnel syndrome or thoracic outlet syndrome or C8, T1 compression. There's a ton of different things that could result in clawing, so you want to make sure that your differential diagnosis is good and always look proximally. So kind of like when we talked about pronator syndrome versus carpal tunnel syndrome, you want to look at where the paresthesia is. If the dorsum of the hand is also having numbness and paresthesia, it's probably not injured at Guillen's canal, because that's after that branch has already come off to the dorsum of the hand. So it would probably be a higher level of compression. But let's say we've confirmed that it is an ulnar nerve injury at Guillen's canal. This will a lot of times happen with constant pressure. So you'll see it in weightlifters. And it used to be really common for bike riders before they started making the handles of bikes a little bit more padded, and then biking gloves became more popular. But for some people, if they're riding an older bike, you'll see compression here, or fractures of the hamate. So usually the hamate will be fractured if you're holding onto something tightly and fall onto it. So let's say you're holding a tennis racket and then you fall. You don't want to drop your tennis racket, so the racket pushes right into the hook of the hamate and can fracture it there. When we say clawing of the hand, what we're referring to is the position of the ring and the small fingers here. What you'll see is MCP hyperextension and IP flexion. So that's both the PIP and the DIP. This happens because there's an imbalance in the intrinsic and the extrinsic muscles of the hand. So what you're losing here is primarily the lumbricals of those two digits. The job of the lumbricals is to bring the MCPs in flexion with IP extension. So when you see this clawing, you can tell that the lumbrical is not pulling the MCP down into flexion. So then the main force acting on the MCP then is the EDC muscle that's largely now unopposed. So it's just pulling back dorsally into extension. Because it's pulling back so much, now the flexors on the palmar aspect of our hand are starting to get tighter because they attach on the middle and distal phalanx. Now they start pulling down, and again, there's no intrinsics to counteract that IP flexion. So then you end up with MCP hyperextension and PIP and DIP flexion. The treatment of this condition depends a lot on the extent of the damage. If the nerve was compressed, like you've been biking a lot, and it's just being pushed down and it's irritated, then that patient might benefit from activity modification. So start using biking gloves and pad the handles. Potentially an orthotic, like the one seen in the photo on the bottom. That's an anti-claw orthotic that's going to correct the clawing position and pull the MCPs down into flexion with IP extension to allow for a more functional position and prevent contracture of the collateral ligaments of the MCP joints. You can work on intrinsic strengthening and work on your ulnar nerve mobility. I would also work on passive motion to make sure that you're stretching it down and it doesn't get contracted again. However, let's say we're talking about our golfer or our tennis player again, who had a hamate fracture at the hook of the hamate. It's possible that the hook of the hamate could sever the ulnar nerve. If there's a complete transection, usually that needs to be a surgical repair. So that would be a little bit bigger ordeal and a little bit more involved therapy. All right, so moving on, we're going to talk about radial tunnel syndrome. So just like the other two nerves, the radial nerve can be compressed as it enters the forearm, in this case through the supinator, near a pretty sharp kind of looking, if you look at it, the proximal edge of the supinator has this sharp looking fibrous band called the arcata fros. This sharp edge, as the supinator is trying, or as the radial nerve is trying to go through it, it can be kind of a sharp edge that's shearing on the nerve and cause some pain there. This patient will have pain in the dorsal forearm and along the extensor compartment of the forearm, so that bulky mass that sometimes you'll hear called the mobile wad of Henry is the technical name for it. So it's really easy to confuse this with any lateral elbow issues. So we used to call it lateral epicondylitis. Now we're calling it lateral epicondylosis or epicondylopathy or things like that. You might see it in cervical radiculopathy, but it's really commonly confused for lateral epicondylosis because it's in the same area. You're looking at that lateral elbow. Radial tunnel, though, is about 4 to 5 centimeters distal to the lateral epicondyle. So if it's a little bit further down, it's more likely to be radial tunnel. For a lot of researchers, as they're looking at lateral elbow pain, it's very likely that with lateral epicondylosis, the primary source of pain is the ECRB, but the radial nerve runs right through there too. So you might have a little bit of spillover with lateral elbow pain into radial tunnel syndrome, but you kind of want to find what the source of all of the dysfunction and the problem is. This radial tunnel syndrome typically gets worse with pronation and supination and with wrist flexion. With lateral epicondylopathies, a lot of times it's flexion and extension because it's the ECRB is the main driver of lateral elbow issues. So if you're extending repetitively over and over, that is going to start to get really sore at your lateral epicondyle. That's not so much for radial tunnel syndrome. The provocative tests are largely the same, so they're not super helpful in determining what's different. So you want to take a good history and really try to palpate for where the pain is. If your patient has radial tunnel syndrome, just like all the other nerve compressions, activity modification is big. So you want to find out what are they doing that's causing this and how can we do that a different way. Make sure you're doing your radial nerve glides and getting that neurodynamic mobility returned. Postural control and strengthening again, core strength. Eccentric strengthening can be helpful if the supinator is really irritable and that's the main cause of it. And for your wrist extensors too, that can be helpful. And then in orthotic to reduce forearm rotation and wrist flexion. So the researchers say maintain wrist at 45-degree extension. Full disclosure, I think that's really uncomfortable. So I usually don't make my orthotics at 45 degrees extension, but tolerable extension. The reason you want that much is because that's how the radial nerve will be in its most relaxed position. Another type of radial nerve compression is called Wartenberg syndrome, not to be confused with Wartenberg sign. I don't know who he was, but Wartenberg must have been very important to have two things named after him. Wartenberg syndrome is compression of the dorsal radial sensory nerve at the wrist between the brachioradialis and the ECRL muscle, especially when the forearm is pronated. Wartenberg sign is it's a sign of ulnar nerve dysfunction. It's resting small finger abduction. So just make sure you're talking about Wartenberg syndrome. A lot of times this happens when someone is wearing a tight watch or bracelet or hair tie or something around their wrist. If you try that on yourself right now, wrap your thumb and your index finger around your wrist and squeeze a little bit. It's right over a pretty bony part of your radius. It does not feel great. So when there's something tight around your wrist all the time, the soft tissues just don't really have anywhere to go except right into the bone. So, it's not crazy, I guess, that there would be compression at that spot. So what patients will experience is pain and paresthesia in the dorsal radial aspect of the hand and wrist. You want to make sure that this is Wartenberg syndrome and it's not, you're doing your differentials and making sure that it's not a higher radial nerve compression. And then it's also common to have in conjunction with de Quervain's tenosynovitis, which we'll talk about in a little bit. But they're both on the dorsal radial aspect of the wrist. So once you know that it is Waardenburg syndrome, you want to do radial nerve neurodynamic mobilization, activity modification, eccentrics for the muscles involved, and you can provide rest for the wrist with an orthotic in neutral deviation and slight extension. Orthotics are really common in nerve compression syndromes because until that nerve gets a chance to rest and recover, it's hard to get it to recover if it's constantly doing the same things over and over. So I think that's where an orthotic can come into play, just to give a little break. An orthotic alone usually isn't going to do everything, because if they take it off and then go right back to the activities that were causing it, it can come back. So you want to do it in conjunction with things, but it is pretty common to see orthotics with nerve compressions like this. The activity modifications, in my experience, can be really, really easy. You might only see a patient for 1 or 2 sessions, and once you figure out that it's Waardenburg syndrome, tell them to take off the watch or switch sides or loosen up the watch band or something like that. Once you figure that out and the nerve compression goes away, the syndrome goes away too. So when we talk about the vascular supply of the hand and wrist, it's pretty simple. There's the radial and ulnar arteries that are coming in from those sides of the wrist, respectively. They form deep and superficial arches with anastomoses. So the nice thing is if you have damage to one artery, it's likely that the other artery can help contribute blood supply to the rest of the hand. These arches will lead to the common digital arteries and the proper digital arteries. It's important to know this because the real estate, especially when we get into the fingers, there's not much extra space. So if there's anything going on that might be causing some compression of the arteries, like let's say you have a proximal phalanx fracture and there's a pretty big fracture callus from the bone healing, or maybe there's surgery and there's a scar with adherence to the artery, it can compress these tiny, tiny little digital arteries and lead to problems with blood supply later on. So you want to make sure that you're looking out for your blood supply of your hand. The way to do that would be to do Allen's test. This is really easy. You can even do it on yourself right now. You apply pressure over both the radial and ulnar arteries simultaneously over the wrist and have the patient pump their hand. I usually do 10 times until the hand starts to look a little bit white and the skin is blanched. Then one at a time release one artery and you can watch the capillary refill. You can see their hand turn pink again. So you know that whichever one you let go, whether it's ulnar or radial, you know that artery is functioning. Then you want to repeat the test for the other side. There is a modification of this test where you can do the same thing for the radial and ulnar digital arteries. So take one finger and compress on both sides and just have them flex and extend the finger. You'll see it blanch and turn white, so let go of one side. I think it's a little harder to do on the finger because it's small, but it's possible. So if this test is positive, that means that there's occlusion of one or both arteries. So you'd want to specify which one and talk to the surgeon right away because that's a pretty big deal if they're not getting blood flow. And that's probably not something we're going to fix in therapy, so reach out immediately. Okay, so moving on from the nerves and the vascular situation, we're going to talk about the bones, the muscles, and the ligament structure of the hand and the wrist. So again, a lot of this stuff is things that you guys are familiar with, so we'll kind of breeze through here. You've got 27 bones in your hand and your wrist. They provide rigid stabilization and provide a base on which to anchor those soft tissue structures. There's 2 types of bones in the hand, your metacarpals and your phalanxes. All the bones in your hand are long bones and have central shafts with expanded proximal and distal ends. There's a few sesamoid bones, but they really vary. And the metacarpals are bowed dorsally, which gives the hand its arches. So if you just look at your own hand, you can kind of see that it scoops in the middle, and then there's an arch over your metacarpals, and then at the base of your hand. When we're talking anatomy, Your hand starts at your metacarpals and includes your fingers. Your wrist is your carpal bones. So just to clarify that. So our wrist is made up of a few different articulations. At the radiocarpal joint, the scaphoid articulates with the radius at the scaphoid fossa, and then there's a small little ridge, and then there's the lunate fossa of the radius. So the radius articulates with the lunate and the scaphoid. The DRUJ is the distal radial ulnar joint. It's where the radius articulates with the ulna at that sigmoid notch in the ulnar head. At the articulating surface of the ulnar head is the seat. The ulna doesn't directly articulate with the carpal bones because of the TFCC, which we'll talk about in a little bit. The carpal bones are described generally in terms of the proximal carpal row and the distal carpal row. However, this is not so clear-cut. Those lines, the red, the blue, and the pink that you'll see, they're called the lines of Jalula. So they're really helpful when you're looking at x-rays to see, is everything kind of in a line? But it's not as clear. That's not how it looks as they move. So in the picture on the right is more accurate to how it actually looks. It doesn't look so clean, like everything is right in a row. They're kind of overlapping, and they're bones with a lot of different pieces to them, and tubercles and hooks and things like that. So it doesn't always look quite as clear. So when we're discussing wrist kinematics, the distal carpal row moves essentially as a unit with themselves, as well as with the second through the fifth metacarpals. The ligaments that we'll talk about in a little bit, the ligaments are really tight and keep them on a pretty tight leash with the metacarpals. So you can think of the distal carpal row and the metacarpals as functionally a single unit. The proximal row has a reciprocating motion with the distal carpal row. So during wrist flexion, the distal and proximal carpal row move in the same direction. They're rolling volarly and sliding dorsally. The distal carpal row is going to follow your fingers. So when you're flexing your wrist, your fingers come down. Your distal carpal row has to come palmarly too, which means that the proximal carpal row is also going to flex forwards, but it has to kind of get out of the way and slide dorsally. The opposite is true for extension. So during wrist extension, the proximal carpal row is going to roll dorsally but slide volarly. So it's following the direction of your fingers. During radial deviation, the proximal carpal row moves ulnarly. So if your whole hand is coming to the radial side, let's say there was no motion, your scaphoid would just be sitting in the way there. So your trapezium and your first metacarpal would start to hit the scaphoid. So to prevent that, your scaphoid and the rest of the proximal carpal row is going to move ulnarly, kind of get it out of the way. It also flexes a little bit and it supinates. During ulnar deviation, it's the opposite. So when we think about then, your hand starts to come ulnarly, your fifth metacarpal is coming down, your hamate's coming down right on your triquetrum. Your triquetrum then has to get out of the way, otherwise it's going to be trapped between the ulna and the hamate. So everything has to move radially, and then it'll extend a little bit and pronate. In both radial and ulnar deviation, the distal and the proximal row are moving opposite each other. With wrist flexion extension, they're moving in the same direction. So in this slide, if I was you guys, I would pause this and really study these diagrams and take a look, because I think it really helps to see the motion. So you can really tell as the wrist is flexing. This diagram is breaking it up. You see the third metacarpal, the capitate, and the lunate, and then you're seeing the radius that it's sliding on. So in flexion, you can see that lunate rolling volarly and sliding dorsally. So it's tilting towards the palm and sliding backwards, and it's the opposite during extension. During wrist rotation, the capitate is about the center of rotation. The shape of the triquetral hamate joint, that one's a mouthful, it controls the proximal carpal rotation. So the way that these two bones kind of fit together, that's where everything is going to start to move. So during ulnar deviation with an axial load, the triquetrum becomes dorsiflexed in relation to the hamate. During radial deviation, it becomes palmar flexed and it moves up, I guess, a little bit higher against the hamate. So the triquetrum or the hamate is going to pull the triquetrum, which pulls the lunate, which pulls the scaphoid, if all those ligaments are intact. So it's kind of this cascade of everything. And it depends on the position of the starting point of the bones and through all those ligaments. So we're going to get into some ligaments in a little bit and see kind of what happens when they don't work. But basically, each bone is going to pull another along with it. So that's why we say, they don't move entirely as proximal row, distal row. They sort of move one on their own in a loose configuration. So the TFCC, this one's a mouthful too, the triangular-fibrocartilaginous complex. The TFCC functions to support the DRUJ, so our distal radial ulnar joint. It also adds to the articular surface of the radius a little bit, and it compensates for a shorter ulna and load transmission. The central portion of the TFCC, that articular disc, is pretty thin, and it doesn't have a great blood supply. The peripheral portion of the TFCC is pretty well vascularized. So what that means is a peripheral tear can heal. Central tear, probably not going to heal. They don't really do surgery for a central tear because it will probably be unsuccessful, so they would likely do a debridement instead of an actual repair. The good news is that the central portion doesn't really contribute to the DRUJ stability, but it does help in load transmission. So they're likely going to have good motion in their wrist, but if they're trying to bear weight, then it might be more painful. That's also how you get a lot of degenerative injuries in the TFCC. So I mentioned it earlier, but because of the location of this structure, the ulna does not directly articulate with the proximal carpal row. You can see in this diagram really nicely how the triquetrum and the lunate are completely separated from the ulna. They get pretty close with weight bearing, but it doesn't actually, the bones don't articulate directly. One other thing to note that's really important about the TFCC, as well as the rest of the carpal ligaments, there's a huge number of proprioceptive receptors in this area. So proprioception in a tear becomes a really big problem, and people have trouble adjusting their wrist position to be accurate and correct depending on the activity that they're doing after a tear. So when you see a patient with a TFCC injury, you want to know if it's acute or chronic. What you'll see is they'll have ulnar-sided wrist pain. That's a really common complaint. You want to watch for ECU subluxation because the ECU tendon sheath is a part of the TFCC. So if you see a tendon snapping around there, it's probably the ECU. The intervention techniques are going to vary completely depending on if it's acute or chronic and the severity of the condition. Typically for a chronic TFCC tear, so if someone is maybe a weightlifter or they're doing a lot of push-ups or things like that, the surgeon is going to recommend first a period of immobilization, which varies drastically. It might be 4 weeks, it might be 12 weeks. And again, a lot of this depends on the acuity and the severity. These can be hard to see on x-rays. You can do a CT arthrogram, but a lot of insurances won't pay for them. So usually they'll send them therapy for conservative management and see if that works first. So they would start with, immobilize in an orthotic, have them just rest it because, it's not supposed to bear weight. It's not supposed to be moving and rotating. So the orthosis that you see on the bottom right, that's called a sugar tong, because it kind of looks, if you think about those old sugar cubes, picking them up with little tongs, is kind of what the splint looks like. In that splint, you can flex your elbow. Usually you can get mostly full extension. It's going to be limited a little bit. The important pieces, though, are you can't rotate your forearm at all because it blocks off the DRUJ and the PRUJ, and it won't let your wrist flex or extend. You do have full motion of your fingers. So after the period of immobilization, and usually some NSAIDs, depending on what the physician wants, then you'll start doing some gentle, active range of motion. I probably wouldn't press and do too much passive range of motion. You know, your goal is stability here. You don't want to lose out on the stability portion of the TFCC. You'll definitely want to work on proprioception training. So this can be done in a couple different ways. The first thing that I like to do, it sounds kind of crazy, and I wish I could show you guys, but you'll have to picture along with me. What I usually do is take a Frisbee, and you hold it upside down, kind of like a platter. So the ridge of the rim is facing up, and you're holding it sort of like you're a server and you're going to deliver it to a table, and you put a tennis ball in it. And your goal is to spin the tennis ball around the ridge of the Frisbee without falling across or staying on one side. This is really challenging for someone with poor proprioception in the wrist because it requires unconscious neuromuscular activation. And you have to make these tiny adjustments in your range of motion and your muscle activation without having time to think about it. So if you don't have good proprioception, you're going to see the ball kind of spinning around in one corner. But this is a great exercise to start with because it's not resistive, it's not heavy, and it doesn't require a ton of range of motion, so it shouldn't push them yet. Another exercise that's really good, this one I found a picture of it. This is using a flex bar, so it's sort of this rubbery bar that you can do it for wrist strengthening. You can take it and twist it and stuff like that. But for proprioception training, you can use it sort of like isometric strengthening too. If you, as a therapist, shake the bar or have the patient shake it, and then keep their wrist stable. Their wrist has to do isometric contractions to hold in different positions to keep the wrist from moving against that little bit of resistance. The next level that I usually do is training with a gyroscope. That is a device, we'll talk about it towards the end of the lecture, but it's got a little weighted metal ball in it and then a plastic covering, and you have to keep the ball spinning by moving your wrist and adjusting your position. The physics of it, the torque, the faster that the ball spins, the more resistance there is, so you have to use more training to control that. This is something I would not do very early with someone with a TFCC tear. Usually rehab is a really, really painfully slow process with TFCC injuries. They can heal really well, but if you try to progress and you're like, okay, let's get to strengthening, let's do weight bearing, you're going to make it worse. A lot of times you might even want to minimize strengthening at all if the joint is unstable in rotation. Strengthening could worsen that. If it's not that unstable, something that could help is strengthening the pronators, because they're going to help with the stability of the DRUJ because of how the pronators connect across from the radius to the ulna. If those muscles are a little bit tighter and do a better job pulling together, they'll help compensate for the lack of stability with the TFCC. So just depends on your patient and their needs. So something else important to talk about when we're talking about wrist anatomy is the ulnar variance. Typically, the radial styloid process should extend about 9 to 12 millimeters more distal than the articular surface of the ulna. If you have a negative ulnar variance, that means that the ulna is lower in the wrist. So the ulna, for whatever reason, is shortened or falling. That can lead to a lot of pain because then instead of distributing the weight between the radius and the ulna, the lunate is now not articulating with the ulna or the TFCC really. So all of the weight of the lunate is pushed towards one side. So there's some discussion of avascular necrosis of the lunate, which is called Kienbach's disease. The research isn't super strong on is that the actual cause of Kienbach's disease, but it's definitely associated. what we often see instead of negative ulnar variance is a positive ulnar variance, which means the ulna, for whatever reason, is too long. So if you're looking at this picture of the x-ray here, if the ulna was too long, you can see that minimizes the space that the TFCC has, so it starts to get compressed. This is super, super painful, especially when your wrist is in pronation. That'll make the ulna a little bit longer even, so any activities in pronation or any weight bearing where the TFCC is bearing that load through it, that'll be pretty painful. So usually with a really painful positive ulnar variance, that would be a surgical repair. So you'll see people after surgery than this. They would do most likely an ulnar shortening osteotomy. So I'm going to show you a picture of that next. So I wanted to share a case study with you guys about a patient that I saw, I think, a year or two ago by now. But anyway, he was a 62-year-old male that fell from a ladder onto an outstretched hand. It was his non-dominant hand, and he fell and fractured his triquetrum. The triquetrum fracture healed pretty well with standard care. He was immobilized for about 6 weeks in a short arm cast and then had a standard therapy, except he continued to have pretty severe ulnar-sided wrist pain, and he worked as a contractor, so he wasn't able to go and use the heavy tools and machinery, couldn't lift things. So he kept going back to the surgeon, and eventually they, in looking at these x-rays, you can tell from that first picture, the radius and the ulna are pretty even height-wise. So they diagnosed him with positive ulnar variance and most likely a TFCC tear. So in the second x-ray, it's a little hard to see his actual radius and ulna, but you can see what they did is they went in and did an ulnar shortening osteotomy, which means that they took a couple millimeters out of his ulna. Depending on the patient, there's not a standard set amount of bone that they take. It depends on how much extra length that person has. But they took a couple millimeters off his ulna and then did a debridement of the TFCC. He did pretty well after this. His wrist stopped hurting. Unfortunately, he did have some swelling. The plate started to irritate him. So then they went back in the next year and took out the plate. Which they typically don't do. Most people don't get irritated by hardware like that, but for whatever reason he did. So I included this x-ray so you guys can see. Now you can definitely tell that the radius is taller than the ulna. The top of that radial styloid doesn't even come close to where the ulna was as compared to that first x-ray. So he did really nicely. He was able to go back to work. So as a therapist, my role in this was not to change the length of his bones. It wasn't to do the TFCC debridement, obviously. That's stuff that we're not going to do. But in the meantime, while all of this was going on, his hand was in a lot of pain. Everything started to get really stiff and really weak. So we were able to focus on motion, maintain all the gains that he was making. After 2 surgeries, he had a lot of scar tissue. So we were working on managing scar tissue to make sure that his tendons didn't become adherent to that external scar tissue. We're working on managing his edema and eventually making sure that we could promote strength without sacrificing stability and make sure that he was able to go back to work. So we gradually worked on bearing load, using power tools and holding on to things with vibration and stuff like that. And he did really well. He went back and has no complaints to this day. So another important thing that I wanted to mention was the wrist position during grip strength. So when you're gripping and your wrist is in flexion, your flexor tendons don't have their ideal mechanical advantage. And same with even wrist in neutral. So wrist in 30 to 45 degrees extension and even a little bit of ulnar deviation is the ideal position for grip. The ECRB and the ECRL kick in to help provide the counter force to the FDS and FDP during grip. So this really helps to make sure that you're able to strengthen in the optimal position here. Okay, so changing gears a little bit, I want to talk about the ligaments of the wrist. This slide is terrifying just even to look at. I am a hand therapist, and I can tell you I don't know all of these ligaments. They do not actually look like that in bodies. They look like a hot mess. You definitely can't differentiate each one like this. So I do not expect you to know these, but I do expect you to know that the wrist is super complex. All the ligaments are interconnected. It has to be. The wrist is so dynamic, so there's a lot of little pieces holding everything together. What I do want you to know about the wrist is two ligaments that are very important for us, the scapholunate and the lunotriquetral ligaments. The reason these are important is because the proximal carpal row is our main mover of the carpal bones. And they have different tendencies of motion. They go together a lot of times, but they're not the same motions. So we're going to talk about this in just a second. I wanted to talk first about the dart thrower's motion. So the dart thrower's motion is something more recent in hand surgery and hand therapy research. It is a more functional plane of motion that combines radial extension with ulnar flexion. So say that again, radial extension with ulnar flexion. The reason this is important is that in a healthy wrist, at least, the motion between the scaphoid and lunate is really minimized, and it prioritizes mid-carpal motion. So it makes the proximal carpal row move more against the distal carpal row rather than the motion within the proximal carpal row itself. So full disclosure, this did look at healthy wrists. They've been trying to study more on wrists with problems, and they're finding this might not be entirely accurate, but dart thrower's motion is a really important plane of motion as we're doing wrist rehab to try and provide a safe way to move the wrist while minimizing the motion of these really important and maybe newly repaired ligaments. So it's called the dart thrower's motion. Imagine yourself throwing a dart at a board. This is kind of the motion, that radial extension with ulnar flexion. So here's where we talk about why those ligaments are so important. Hopefully this isn't too graphic for anyone. I don't think so. But when I was learning this from my mentor, who is a PT, CHT, and she is amazing, she described the lunate as promiscuous. So the lunate just follows whoever is still around. So the triquetrum tends to extend. The scaphoid tends to flex. The lunate sort of balances them out, and the connection between the SL and the LT ligaments keeps them all together. But if the SL ligament is torn, meaning the scaphoid is on its own, now the lunate is only attached to the triquetrum, the lunate will tip back into extension. It just goes and, okay, triquetrum wants to do that. We'll do whatever you want to then. That is called a DISI injury, or a DISI. It's a dorsal intercalated segment instability. On the other side of things, if the LT ligament is torn, so now we have our scaphoid that's trying to flex, the lunate's holding it back, but that ligament is torn, so now the lunate, it'll just flex along with the scaphoid. So the lunate becomes positioned in this flexed position, which is a VISI injury, a volar intercalated segment injury. Usually these injuries occur from a pretty high energy foosh. Sometimes you can see them on x-rays, sometimes you can't. If you can see them on x-rays, typically it's a pretty severe injury that's going to need to have surgery. A lot of times they'll pin the bones together, so they'll pin across the ligament and keep the pins in place for up to 4 to 8 weeks with a cast, and then therapy can begin once the cast is removed. Usually you don't progress with strengthening or weight bearing until a pretty long time after, depending on the type of surgery, because you don't want to sacrifice all the stability that you just gained through the surgery in favor of mobility. Mobility can come back later, but the point of the surgery, the point of wearing a cast for that long is to keep it stable. So you want to make sure in your therapy you're being really gentle and really cautious and not just pushing to get people back to their injuries or back to their activities and potentially re-injuring them. So if you have one of these injuries, the dizzy injury comes from an SL ligament tear. Usually that's from a fall with wrist extension, an ulnar deviation, and some forearm supination. So when we're doing an evaluation, you would look for a Watson's test. That's a scaphoid shift test or a scapholunate ballottement test. We'll go over those later in kind of our lab section. For interventions, what we would do initially is immobilize, whether it's immobilization during a post-op period or just immobilize for a couple weeks. There's a few muscles that are really helpful because they can keep the scaphoid from flexing too much. That's the FCU, the ECRB, and the APL. So going back to our dart thrower's motion, we're extending our wrist to the radial side and flexing our wrist to the ulnar side. So that's the FCU, the ECRB, and the APL. The FCR is a little bit questionable because depending on the position of the wrist, sometimes it pulls the scaphoid actually into more flexion. So be careful with it. It's not an absolute no, but a caution. The one thing that you really want to avoid strengthening is wrist extension with ulnar deviation. So that's your ECU, because that increases the pronation of the scaphoid. So it's kind of twisting the scaphoid within its spot, which is going to stress the SL ligament again. When you do immobilization, that's why you probably want to immobilize the wrist in neutral. So again, you want to start with your dart thrower's motion, even just active motion. You can do this when you get to your isometrics. Have them do isometrics in the dart thrower's plane of motion, and resistive exercises then too, eventually with either, you can use TheraBands or little free weights, things like that, but not until it's safe to do so and you know that they have really good stability. So what happens if a dizzy wrist is not treated? Well, without the stability of the scapholunate ligament, the scaphoid and the lunate start to migrate away from each other, which creates this big gap. So then the capitate starts to fall and migrate proximally into that empty space and forms what's called a slack wrist. So that's a scapholunate advanced collapse. This is bad because it's creating articulations that don't go there. It is extremely painful. The wrist kinematics are 100% thrown off. Nothing works well. So you limit range of motion, you limit strength, and it's really painful. You can a lot of times like feel and almost hear it grinding, and this is most likely a surgical fix. There's a few different ways that they can approach this. Sometimes they do a proximal row carpectomy and just take all of the bones out that are not functioning well anymore. Sometimes they will try to do a repair and pin the bones back together to create those joints. Sometimes they just do a whole fusion. So those would be highly dependent on the patient condition. If you have an LT tear, that would cause your VISI injury. So this often occurs from a fall backwards on the outstretched hand with the arm externally rotated and forearm supinated. Your wrist is extended and radially deviated. In this position during the injury, what happens is the pisiform will impact against the extended triquetrum, but then the lunate's kind of constrained dorsally by the radius, so the lunate can't go further backwards with the triquetrum, so you'll have that tear between the two. We would confirm this in therapy using the LT ballottement test or the LT shear test. If this is positive, what we would do is start with initial immobilization with a 3-point orthotic. So what that means is there's 3 points of pressure that blocks the pisiform that helps kind of maintain the carpals in realignment. So that's kind of a fancy splint, but it just makes sure that instead of everything tilting volarly, you're able to redirect all the forces so that they're in alignment again. You know, it's not great. It doesn't put the ligament back in place, but it at least is really good for managing pain. What you also want to do is reestablish the proprioceptive control. So very similar to what we talked about for the dizzy injury, only the muscles that you want to focus on now are the FCU and the hypothenar muscles can really help pull the triquetrum back into more of a flexed position. Again, this is really helpful for dart throwers motion because it minimizes the motion of the proximal carpal row and prioritizes mid-carpal motion instead. Okay, so we've danced around weight bearing a little bit, but this diagram I love because it shows where the forces are directed in percentage through the carpal bones. So you have primarily, we're going to focus on the proximal carpal row and then the radius and the ulna. So you can see that the S is scaphoid, lunate, and triquetrum. 46% of the weight is going to go through the scaphoid onto the distal radius. The lunate is kind of split between, it would be the TFCC and then the ulna, but the lunate kind of splits that load, and then the triquetrum is all through the lunate. So then in the distal row, the major load-bearing bone would be the capitate. Your distal radius, there's some different literature, some saying 70 to 85% of the load. Usually I go with about 80% of the load is at the distal radius, and then 20% through the ulna via the TFCC. The forces eventually get dispersed in the forearm through the interosseous membrane, so then by the time you get to the PRUJ, or the proximal radial ulnar joint, 80% is through the ulna and 20% goes through the radius. So what that means is these are the most commonly fractured bones, the ones that you'll see listed here. The scaphoid, lunate, and the radius are the most commonly fractured of our wrist bones. So distal radius fracture is something super common. It is the most common upper extremity fracture. This is common in both younger populations, very activity dependent, especially in rollerblading, skateboarding, and snowboarding, because you'll fall a lot in those activities, especially if you're just learning. And then older adults, especially those with lower bone density. These occur from falls on outstretched hand. The fall, it's not like, oh, it has to be in a pronated hand or it has to be in this position. The position of displacement of the bone, that's what depends on the position of the fall. So if I fall forwards and a piece of the distal radius cracks off, it's probably going to be tilted dorsally. If I fall on the back of my hand and the bone is pushed volarly, that's going to be at a different position. So you'll hear a lot of different kinds of classification and names of fractures. I think they're worthwhile to mention because they are still out there. But just so you know, fracture classification and discussion is really trying to go away from named fractures because they don't tell you very much about the prognosis or what's actually going on. So the two common ones that you'll hear, though, are a Colles fracture, which means that the portion of the distal radius that was fractured is dorsally displaced, so meaning it's tipped kind of towards extension. A Smith fracture is the opposite, so that would be a volar displacement. In orthopedics, they're trying to, instead of saying, oh, this person has a Colles fracture, they're trying to describe more now, is it intra or extra-articular? What's the fracture pattern? Is it comminuted? Is it non-displaced? Things like that. And they're trying to focus more on client fractures too. These are distal radius fractures are also pretty common to see with ulnar styloid fractures. If you're falling that hard and that fast, the tiny little tip of the ulnar styloid would break off, but usually those are not a big deal. They'll heal pretty well without specific intervention for it because usually in a distal radius fracture there's some type of immobilization. So whatever immobilization is decided upon for the distal radius fracture, that'll usually be fine for the ulnar styloid fracture as well. So what do we do then as therapists to manage these distal radius fractures? If it's a surgical fix, there is a really wonderful trend towards volar plating. So that means they take these plates and they go through the volar aspect of the wrist. There's a million different sizes and shapes so they can fit it right to there. They used to do more dorsal plating, but if you just look at the back of your wrist, you can see your extensor tendons run right over there. So tendons were rupturing a lot and they were causing a lot of problems. So these volar plates, now that they're buried under a lot of soft tissue and the tendons don't tend to run right over them, usually have a little protection, these work great. The other benefit of this is that we can start moving really soon, sometimes within the first week even. The earlier people move, the better the outcomes are going to be. So if they're coming to you after a surgery, after an ORIF, usually active range of motion you can begin within the first week, passive range around 6 weeks, and strengthening at 8 weeks. You also want to manage scar tissue. You're going to have to manage the wound healing as well and make sure that, in the meantime, while they still have their stitches or staples, they're not getting an infection. You want to make sure that they're not getting scar adherence and things like that. And there's some other complications. Sometimes you'll have median nerve compression if there's a lot of swelling and, they're digging down pretty deep into the wrist to get that plate in, and then the fracture itself, the bone fragment might cause some compression on the median nerve. You can get CRPS, tenosynovitis. On the dorsal aspect of the hand, you can get the dorsal radial sensory nerve compression. You can have ulnar nerve compression. You have DRUJ issues. There's a lot of possible things that can happen, but typically these cases will heal really nicely. One other thing that I want to mention is what happens to the more proximal joints. So when someone has surgery, or even if they don't have surgery and they're in a cast, usually as they're sent home from the hospital or from surgery, they'll get put in a cast or a post mold and they'll put a sling on them. Slings are the worst. Throw them away unless there's a really true and valid reason why they need them. But what happens when someone wears a sling, even for a week, their elbow stays in flexion. And you guys have already done the elbow unit, I think, so you know that the anterior capsule of the elbow gets super tight and is really prone to elbow flexion contractures. And then their shoulder is stuck in internal rotation. So now, in addition to your distal radius fracture, you have to worry about all these other joints. So get rid of slings. If they are immobilized for a little while, if they're not a surgical case, if they can be conservatively managed with a cast, even if you can't move their wrist, it might be beneficial to have a therapist pop in and see them right when that cast is put on so that you can start working on range of motion for the fingers. If people don't move their fingers for 4 to 8 weeks while they're in a cast, you can better believe those fingers are going to get super, super stiff. So for all joints, the earlier the motion, the better it is. So within the carpal bones, the scaphoid is the most commonly fractured carpal bone. This happens a lot with high energy trauma in younger males between 15 and 30 years old. This injury is usually caused by wrist hyperextension greater than 90 degrees with radial deviation and compression. So when we're talking about scaphoid fractures, we really have to think about the particular position of the bone and what it looks like. So I recently read an article where they described it about cashew-sized and shaped. I thought it's kind of a nice way to picture it. But the scaphoid has 3 very distinct parts: the proximal pole, the waist, and the distal pole. The scaphoid is an interesting bone because the blood flows in from the distal pole to the proximal pole. It does not start proximally. So what that means is if you have a waist or proximal pole fracture, that distal part is doing great. It's got all its blood supply. The proximal part, though, doesn't have any blood. It's not getting enough nutrition. So a lot of times you'll get avascular necrosis, or they'll have to have surgery. In the majority of cases that we see, a scaphoid fracture needs to have some kind of fixation. These fractures are really important for us as therapists to think about because they're missed on x-rays a lot of times, because when you think about how many ligaments there were in that one slide on the wrist ligaments, there's a million there holding everything in place, even if the bone is fractured. So the ligaments might be holding it there, so you can't see that there's a gap in the scaphoid. But if there is, it might not show up on x-rays for a couple weeks. So if they fall, go to the emergency room, it looks great, but then they're still telling you they have pain a couple months later, you might want to relook at that. So just like everything else, the management of scaphoid fractures depends on the severity and the exact location. But the scaphoid screws are a little bit newer technology. They're a little nicer because they don't go into the joint space, whereas the older way for fixation, they use Kirschner wires or pins. So that did go through the joint space. Immobilization it runs the gambit between 2 weeks and 6 weeks post-op. Usually you can move them a little bit sooner with a screw, which is why I like it. They will be immobilized either with a short arm cast or a thumb spica. A thumb spica is similar to a short arm cast, but it's got a little extender up to the thumb, so you can still move the IP joint of the thumb only, but it'll immobilize the CMC and the MCP. There's debate on which one is better. They used to think that the thumb had to be immobilized because it's on the radial aspect of the wrist, and that might make the scaphoid move too much, but now they're saying, no, it doesn't, the first metacarpal doesn't articulate with the scaphoid, so it should be fine. So, kind of depends on what the surgeon wants. The conservative management of a scaphoid fracture, even if it is a distal pull, which has better blood supply, it's going to be pretty slow. So it's going to take 8 to 10 weeks to heal for a distal pull. If it's the waist of the scaphoid, it'll be 6 weeks in a long arm thumb spica. So what that means is the elbow is immobilized as well, followed by 6 weeks in a short arm spica. The proximal pull fractures, remember, these really don't have good blood supply, so typically these will be surgical repairs, but for whatever reason, if they're refusing or they're not medically stable or whatever else is going on, it'll be 6 weeks in a long arm and then 6 weeks up to 6 months in a short arm thumb spica, just kind of waiting around for that bone to heal. Whenever they can start moving, you want to do really gentle, active range of motion first. Kind of let them go as much as they can, and then definitely wait at least 3 months to start strengthening or weight bearing to make sure that there's good stability and good vascularity. You'll need to manage edema and digital motion in all cases, and then for surgical cases, any scar tissue that comes up too. And just be really slow and gentle with these guys too. You don't want to sacrifice your new stability just to get mobility and then re-injure. So this is an example of an order that I received from a primary care physician last year for an 18-year-old male that just said wrist pain. The doctor's note said that he had wrist pain for 8 months after a fall, and they were like, well, we'll send you for x-rays and go to OT. And he called, and we had a last-minute cancellation, so we got his appointment for the next day, went over to radiology, got those in, and then I was doing my chart reviews before I went home, and I was looking at his x-rays, and I was like, oh, that's a non-union scaphoid. Like, that's terrible. But the primary care physician hadn't seen it because it was just that morning. So I was like, I like to think I'm a pretty good therapist, but I cannot heal a non-union scaphoid fracture. So what I did was I sent this x-ray, and I sent his chart over to the hand surgeon, and then called his PCP. And they were able to connect, and instead of coming to see me, he had surgery that week to repair that. So the takeaway lesson is that make sure that you're doing your chart review, look at those x-rays, because no matter how good of a therapist you are, if you're trying to, like, let's say this kid's wrist was really stiff. I don't know. I didn't actually see him. But if his wrist was really stiff and you're trying to do joint mobilizations and you're pushing right on that scaphoid, you're probably going to make it worse. You could hurt him by mobilizing structures that are not there and don't have good blood supply. So you can tell, I have the scaphoid circled in his x-rays, and then you can see the normal ones. That's what it should look like. So just make sure that you're doing a good chart review and paying attention to these kind of fractures. So moving on from bony anatomy, we're going to talk about the muscle anatomy. So wrist flexors, you got your FCR and your FCU. Palmaris longus, sort of. It technically is a wrist flexor, but it doesn't really do that much. Your wrist extensors, ECRB, ECRL, and that should also say ECU. Your finger flexors and extensors help with your wrist motion because they technically cross the wrist joint, but they're not the primary movers, so don't really count on them there. Supination is controlled by the biceps and the supinator. Despite its name, the supinator is not the primary muscle that controls supination. It's the biceps. So with any supination issues, train the biceps. For pronation, you have your pronator quadratus and your pronator teres. On the dorsal side of the wrist, everything is organized by compartments. You can read the compartments here, and you can see how they're written out there. But these are important because each compartment has its own synovial sheath and synovial area. So problems are often isolated to one compartment, which is important to know for infections, but can also kind of tell you about what other structures are involved. So everyone's probably heard of de Quervain's tenosynovitis. This is a problem in the first dorsal compartment, so the APL and the EPB tendons. This is caused by forceful or repetitive thumb abduction with wrist flexion. In therapy, we do either the What test or Finkelstein's. Intervention for this is widely variable. One of the most beneficial things is immobilization with a corticosteroid injection. But we can also look at other things like eccentric loading of those tendons, activity modifications, and immobilization with a thumb spica orthotic for sometimes up to 6 weeks. This you'll see a lot in patients who are new mothers, because when you think about holding a newborn, you're really supporting them with your wrist in flexion and your thumb is out to catch their side. You can see it in work activities a lot. So I recently had a UIH employee who, for her job, had to do a lot of cardiac ultrasounds. So she was trying to move in strange ways to get around the ribs and things like that. You'll see it pretty commonly in hairdressers for people cutting with scissors. So as you're going through your therapy, you also want to think about what kind of activity modifications, how can we adjust these things? Or are you using a lot of wrist flexion and thumb abduction to compensate for weakness more proximally? And how can you train those proximal muscles to kind of make up for that? If therapy isn't effective, and the injections aren't effective, immobilizations aren't effective, all of that stuff, then they would probably go for surgery. Surgery, to me, is kind of similar to a carpal tunnel release in that what they're doing is they're releasing the ligament that goes over the first dorsal compartment just to give them a little bit more room to breathe so they're not so tightly pushed down against the radius. So it's pretty similar to that protocol too. Usually I'll see people for 3 visits. First to go over some active motion, the next week take out their stitches and talk to them about scar management. Third week, maybe start on some strengthening, and then they're good to go. Again, this is a nice procedure because you don't have to worry about damaging any structures. Nothing was repaired. They went in and did damage. They cut the ligament apart. You're not going to cut it. You're not going to damage it more. You know what I mean? So people tend to do pretty well if it does come down to that. Hopefully it doesn't, but just in case, people do tend to do pretty well. Okay, so pretty briefly, we're going to talk about some hand anatomy. So just again, that starts with the metacarpals and goes distal into the digits. So in this picture, we can see the arches of the hand. There's the longitudinal arch. So when your hand rests, your fingers kind of rest into flexion. You have your distal transverse arch and your proximal transverse arch. This I wanted to bring up because this can give you clues for measurement and provide some information on dysfunction if there's flattening of the arches or things like that. In today's really fast-paced healthcare world, sometimes I don't have enough time to measure everything during an evaluation that I want to. So I'll use the distal or transverse proximal arch to help me measure finger range motion. So what I mean by that, if let's say you have someone with a distal radius fracture, and their fingers are really stiff and they can't make a fist. If I was going to measure finger flexion, I would have to measure the MCP, PIP, and DIP of all 4 digits and the thumb. That's going to take me a really long time and probably isn't the main focus of my evaluation since they're here for a wrist injury. So what I can do is measure how many centimeters from the tip of each finger to the distal transverse arch. So you can say, okay, index finger, 3 centimeters, middle, 4, whatever it is, just to give you a baseline so you know how people are improving. There's no standard numbers or anything for it, but I just wanted to give you guys an example of why these things might be important in your practice. So earlier we were talking a little bit about how the distal carpal row and the metacarpals interact with each other. And I really like this picture because I think it sums it up really nicely, that the first, fourth, and fifth are mobile. They move, not a ton. The first CMC joint obviously moves a ton. The second and third are really fixed. So they increase the stability of the hand. That allows you your tight grasp. And even as you're making a fist, watch to yourself how your fourth and fifth digits kind of curl in opposition to meet your thumb. Your index and middle fingers don't really move at the CMC joint. So with that first CMC joint, I think one thing that's really important to talk about is how it moves and what are the words that we use to describe. So I would pause this slide for a second and really look at the difference between palmar and radial abduction, as well as flexion and extension, because it's hard when you're reading articles or when you're looking at home exercise programs and they say abduct the thumb. You're like, okay, but where and how? So it's good to make sure that everyone's on the same literal plane of motion as we're talking about this stuff. So that first basilar joint, that CMC of the thumb, is really important to basically do everything that we do throughout the day. So one really common problem that you'll see is CMC arthritis, either from RA or OA. And this picture really nicely shows the pattern of dysfunction that you often get. So what happens is the collateral ligaments surrounding the CMC start to get broken down, and they're not providing a stable base for the CMC. And because the first metacarpal has so many different directions that it can move, it's inherently unstable. So what happens then, you lose your static stabilizers, you lose your ligaments, and all you have is your dynamic stability. In your thumb, the adductor pollicis is a super strong muscle. So what that's going to do is pull your thumb, pull that first metacarpal into adduction. So adduct your thumb. What happens is that first metacarpal goes towards the second metacarpal. So your thumb is kind of like smushed into your hand. That is not a very functional position. So then what you try to do is you use your extensors. Okay, I'm going to bring my thumb out. But because of the way that the EPL is attached to your thumb, it's going to pull from the distal aspect first. So then your MCP starts to come into hyperextension, which means that the volar plate at the MCP joint becomes so stretched and might even snap there. So now you have the proximal phalanx that's tilting away and causing sustained hyperextension at the MCP. Meanwhile, because the adductor pollicis is still pulling that first metacarpal down into adduction, the base of the first metacarpal can slip dorsally and become displaced there. So then you have more distally your IP joint. It's trying to extend, the flexors are tightening, so it can move typically. It's not fixed in one position or another, but both the EPL and the FPL will get taut, so the IP gets really stiff too. The subluxation of that first CMC is called the shoulder sign, so you'll see it slip off. And that becomes worse with any adduction of the thumb. So what this means for us, because of this whole cascade of events, do not strengthen the adductor pollicis. A lot of people with hand arthritis think, oh, I'll just do some strengthening. I'll work on pinch and grip. You do not want to give general strengthening exercises. You want these to be really targeted at what exactly are the problems here. What is happening to cause this dysfunction? So we want to work on dynamic stabilization. So in addressing dynamic stability with CMC, this is the home exercise plan that I usually give people to start out with. Their very first, even their evaluation session. These are the 3 exercises that I'll give. There's 2 things that you need for it, a tennis ball and a rubber band. We have graded rubber bands, so the lightest one is a 5-pound yellow band resistance. But first, what we want to do is work on the isometric strengthening of your thumb using the tennis ball to hold in that nice C position. So some people will try to hold in a different grasp with their thumb in adduction or anything else. Our goal is to get that C position, so it's in mid-opposition, mid-flexion, but the CMC is stabilized, so it can't kind of collapse into that position of deformity. The second exercise is for thumb opposition. So this is where we work the opponent's pollicis and the abductor pollicis brevis. All you do is lift the index and middle finger off the ball. So your thumb has to kick in and hold in opposition. If those muscles weren't active, the ball would fall out of your hand. The third exercise, this is the most important. This is kind of the key to everything. We're trying to work the first dorsal interossei. So this is where you have the rubber band wrapped around the proximal phalanx to make it easier, the distal phalanx to make it harder, and they're going to hold the tennis ball lightly and try to lift the index finger and move towards the thumb away from the index finger. So if you palpate right now in that space, the dorsal CMC, or in the space that the first dorsal interossei will be, and try to abduct your index finger to activate the first dorsal interossei, you'll feel it contracting. And it again helps seat the CMC, or seat the first metacarpal back on the CMC. These exercises should reduce pain. They should not make it hurt worse. If it's hurting worse, it's probably doing something wrong. So I tell patients to start every other day, 10 to 15 reps with 5-second hold, just 50% effort. You don't even have to squeeze all the way. So these are some nice introductory, easy things to do to help correct the dynamic stability of the thumb. The other important thing, kind of in the bottom left that I have here, is joint protection. So if people do these exercises, but they keep doing all their same activities and their thumb is collapsed and they're using it the wrong way, it's still going to hurt all the time, right? So we want to start with some joint protection techniques, really basic to start out with, that I'm sure you guys have heard before, but the one that I want to point out is use a 3-point pinch instead of a key pinch. So a 3-point pinch, I want you to bring the tips of your index finger, your thumb, and your middle finger all together. You can see how your thumb is in mid-opposition, a little bit of flexion, versus a key pinch. So now imagine that you're twisting a key in a door. Your thumb comes into adduction. If you're doing everything with a key pinch, you're going to strengthen the adductor and make that pain worse. Do not use a key pinch. Use 3-point pinch instead. So let's take a break from the thumb, and we're going to talk about the long flexor tendons of the fingers, meaning FDS and FDP. They travel together through the carpal tunnel, and then they pass into each tendon sheath for the digits. The FDS travels on top. It's called the flexor digitorum superficialis versus the flexor digitorum profundus. So that means it travels on top of the FDP until it gets to an area known as the Camper's chiasm. So Camper's chiasm is where the FDS split, or FDP, kind of comes between the split of the FDS tendon. So when FDS splits, that allows FDP to then come more palmar, and FDP rejoins again to connect on the middle phalanx, but now it's actually dorsal to the FDP tendon. So this is a really tricky area for rehab because things are so tightly packed together and wound together. You can see in this diagram the vinculum. That's how the tendons get their blood supply. So any issues with one tendon or the other might impact that blood supply. Now these tendons, you can see in that second picture, I like how they lifted up the tendons from the fingers. So you can see they're only attached at the end and through those tiny little vinculum. They're not secured very well. So in a second, we're going to talk about how do the tendons stay firmly against the bone and they're not moving all around within the finger. So within your intrinsic muscles of the hand, hopefully everyone remembers their palmar and dorsal interossei with your pads and dabs. So they're responsible for the abduction and adduction of the fingers. The lumbricals, which are responsible for MCP flexion and IP extension. Your thenar muscles, which there's technically 3 of them. It's your abductor pollicis brevis, your flexor pollicis brevis, and your opponens pollicis. We also kind of mentioned earlier about the adductor pollicis that it's not technically a thenar muscle because it's deeper to them, but it's intrinsic to the hand and it only acts on the thumb. But it is in a different compartment technically, and it's innervated by the ulnar nerve, whereas the rest of the muscles are innervated by the median nerve. The hypothenar compartment is a mirror of the thenar compartment. There's an opponens, a flexor, and an abductor. So our flexor tendons, now that we've gone through them, are divided by zone, starting distal to proximal. Zone 1 in your fingertips, zone 2 kind of crossing your fingers into your palm over the metacarpals, zone 3 within your palm between the carpal tunnel and the metacarpals, zone 4 just proximal to that, and then zone 5 in your wrist. Your thumb has different zones because, it doesn't have an FPL and it has the FPL rather, it doesn't have the FTP and the FDS. Your zone of injury will really inform treatment and prognosis. So for example, as hand therapists, probably one of the toughest things that we see is a zone 2 flexor tendon repair. So you see a lot of people with cooking injuries where they're trying to cut maybe a piece of meat, or the last one I saw, she was trying to cut a lime and the lime slipped and rolled away and she ended up slicing through her ring and small fingers. This is really difficult because of what we just talked about with Camper's chiasm. There's not a lot of extra space, and the tendons are trying to slide around each other and over each other, so it gets pretty complicated in there. They also don't have great blood supply. You saw this tiny little vinculum, so if those are injured, it's much harder for the tendon to get enough nutrition that it needs to heal. Zone 1 only has the FTP tendons, so potentially a little bit different healing process, I'll say that. So when we talk about these long flexors and how are they attached to the rest of the fingers, we talk about the pulley system. So you have the annular and the cruciate pulleys. So that's the A and the C. The annular pulleys kind of wrap around the tendon sheath to keep the tendons close to the bones. The cruciate ligaments do the same. They just cross in an X. These are the whole pulley system. They're all parts of the fibrous portion of the tendon sheath, and they can help maintain some of that synovial fluid and synovial motion as well. Without the pulleys, what happens is the force of the tendons, as they're pulling, they can create something called bowstringing, which we'll see next. So the pulleys are really important to make sure that the tendons go where they're supposed to and they stay against the bone to give them the best line of pull, really, when you talk about like the best mechanical advantage of the pull. The A1 pulley is important to note in a condition called trigger finger, and the A2 and the A4 pulleys are often injured with rock climbers who are using their tiny finger flexor muscles to pull their entire body weight. So those flexor muscles, when they're pulling so hard and their life depends on it, sometimes the pulleys will rupture and then you'll get this bowstringing. So this is what bowstringing looks like. As the tendon bends, you can see how the whole tendon is trying to pull away from the bones and pull away from the fingers. In some injuries, in some flexor tendon repairs, when they're trying to sew the tendons back together, they get really bulky and they're hard to pass under. So some surgeons are starting to allow bowstringing on purpose to provide a stronger repair. But in general, you don't want to have bowstringing because that decreases the mechanical advantage. When you think back to your physics, this decreases the mechanical advantage of the flexor tendons. So you actually will lose finger flexion and it won't be as strong either. So you really don't want to see bowstringing. When you have a problem with the pulley system, though, you can develop something called trigger finger. So what happens is the flexor tendons, as they try to pass underneath the pulley system, sometimes they can get inflamed and have a nodule right under them where that nodule just can't fit and it can't pass anymore. So it can bend because then the tendon and the tendon sheath kind of migrate proximally, but to extend, it would have to try to slide underneath that pulley system and it just gets caught. So the joint, usually it's at the MCP. Sometimes you'll see it at the PIP too. It gets locked in flexion. It can occur at any finger, including the thumb. It's most common in the ring finger and the thumb. And what you would look for is there'd be a catch in that transition from flexion to extension. They'd kind of get stuck down. And there's a few different grades of trigger finger. It might just be painful. It might actually trigger, but they can extend it on their own. Grade 3 is where it triggers, so it gets stuck, but using their other hand, they can pull it back. Or grade 4 is where it gets stuck, and then no matter how much they pull, they can't get it to extend all the way. So what you would see is that catch. It'd probably be painful, and there might even be a palpable nodule over the A1 pulley. So you'd want to palpate right over, and if they're like, yep, that's the spot, it's pretty likely to be trigger finger. There's not a ton of other things that it might be if it's just in that area. There could be something like a flexor synovitis or something else going on, but with that locking, that's a very clear sign of trigger finger. So management in therapy, we typically do in orthosis. We can't make that nodule go away. It's got it with rest, though it can. So you can block the MCP in extension, or you can block the PIP in extension. More evidence is trending towards PIP blocking to just keep that joint straight. So you make a tiny little splint or use what's called an oval 8 splint to keep it in full extension. People barely have to think about it. It's really easy to do and wear. So that gets really, really good results usually. You also want to make sure you're managing their pain. Do activity modifications if this did happen from frequent heavy lifting or something like that. And then usually from the physician side, they'll manage it with a steroid injection, a corticosteroid, to decrease the inflammation of the tendon sheath. Sometimes that's enough to heal it. If it's not, then they would do a small surgery where they release the A1 pulley. So this is kind of similar to our carpal tunnel release or our de Quervain's release. They're going in, making a very small incision to open up a ligament or a fibrous band of a tendon sheath to allow the tendon to move more. So these tend to heal really well. In that same progression, when you go back to that slide on the carpal tunnel, 3 sessions, 1 to work on active motion, 2 to manage the wound, 3 to work on strengthening. And then you're done. There's still all the potential for complications, as with any surgery, but it's still, they tend to do very well. So in other anatomy, other things that are important to know are the volar plates. So the volar plate in our finger is a structure that occurs on the volar side, obviously, to prevent from hyperextension injuries and to prevent from dislocation. This is a structure that's present at the MCP, the PIP, and the DIP. When you flex, it'll kind of fold and like crunch up into itself, and it slides a little bit proximally. When you extend your finger, it has to slide distally, and it becomes really tight. The tricky part is when it folds into flexion. It's all kind of crumbled up on itself. If it stays in flexion for a long time, then it'll curl in on itself and it stays there and it gets contracted. So PIP flexion contractures are a pretty big deal that a lot of times will happen. You'll see it a lot in athletes where they'll say, oh, I just jammed my finger. It's not a big deal. And swelling will force the finger into flexion for a long time. And if it's flexed for long enough for that volar plate to scar down on itself and stay stuck in that flexed position, it's really hard to extend it again. So here we look at, in a little bit more detail, the volar plate as it's coming into, as it's crossing over each joint. The side parts are known as the check rein ligaments. So this is pretty much the same information as the volar plate, but I wanted to include it because when a contracture is becoming such a big deal that they need to do surgery, usually the check rein ligaments are one structure that will be released. Something else that's really important in each of the 3 joints of the fingers are the collateral ligaments. So the collateral ligaments run on both the radial and ulnar side of each digit at each joint, and they tighten in flexion, and then they become loose in extension. So I think this picture does a really nice job of showing how when it's extended, it's kind of loose and wavy. So they can cause contractures when they're extended. This is primarily true at the MCP. So typically if someone has a fracture of the hand or for whatever reason needs to be immobilized, you want to make sure that this collateral ligament doesn't tighten up if it's allowed to be fully extended. So you want to position the MCPs in about 70 degrees of flexion when you're fabricating these types of orthotics. There are some exceptions. So if you have a Dupuytren's contracture release, you'll have to have the fingers fully extended, but for the most case, you don't want the collateral ligaments to tighten, so you make the splints in that safe position. So focusing specifically on the MCP joints, there's 2 different structures that I want to talk about. There's the sagittal band of the index finger, middle, ring, and small that goes across the dorsum of the MCP joints to keep the extensor tendons in place. And then the other structure that I want to talk about is the volar MCP of the thumb usually will contain 2 sesamoid bones. Those don't necessarily, they don't do too much, so you don't have to worry about them, but if you see little floating things on x-rays, that's probably what they are. With the thumb specifically, the collateral ligaments, both the radial and ulnar, are pretty important for stability because your thumb is out there doing so much. So a UCL injury, so the ulnar collateral ligament, is called a gamekeeper's thumb or a skier's thumb. So when you think about skiing with poles, you're holding something in your hand, the pole gets caught, and it stretches your thumb out to the side and completely tears away that ligament. So then when you go to grasp, you don't have good stability. A radial collateral ligament would be the exact opposite, and that your thumb is pushed in towards your hand and you lose stability on that side. So now switching gears and talking a little bit more about the extensor mechanism of each fingers. First, I just want to say this is really complicated stuff. I think it's really fascinating, but it's hard to get, so don't worry if you're having trouble with it. It's not as bad once you look at it a couple times, I promise. So stick with me. The first thing we want to look at is in the middle of this drawing, the long extensor tendon that's coming through. So that's our EDC tendon, our extensor digitorum communis, that comes over, crossing the MCP right over the middle. The central tendon is not directly or functionally attached to the proximal phalanx. It inserts on this mess of a structure called the extensor hood. So that's really just a band of fibers and ligaments that kind of weave around the finger. So it doesn't insert right onto the bone but the extensor hood will insert onto the bone. The sides of the extensor hood kind of wrap around the finger to attach volarly. So it's wrapped around the whole top, and that's at the MCP level, that's what makes the sagittal bands to help anchor and stabilize that tendon. So it's important that it goes around the MCP to make sure that that central tendon doesn't slip and slide around to the sides of the finger. From this view, we can see that continuing distal to the MCP joint, the extensor tendon then will separate into a central band that goes in the middle, and then a pair of lateral bands on the sides. The lateral bands are just dorsal to the axis of rotation of the PIP joint. So they're not right in the middle of the finger. They're not on the back. They're not in the front. They're just a little bit dorsal. And then that central band will continue to cross over the PIP and attach just to the dorsal base of the middle phalanx. The lateral bands, they're splitting, so they go to either side of the PIP joint, and they attach dorsally. They kind of come back and join together on the distal phalanx. The lateral bands are really important because that's where the lumbricals and the interosseous muscles eventually insert. The position of the lateral bands is really, really important to maintain the normal position and normal balance of the fingers, and it's got two fibrous parts to support that. So there's the triangular membrane that connects the lateral bands just dorsal over the middle phalanx and over the PIP to prevent volar migration. So what that means is it makes sure they're staying in the back and they're not slipping towards the front of the finger. Because you can see from this picture, the lumbrical muscles are coming from the palmar aspect. So if they're just pulling down on the lateral band, it could slide down. But because we have that triangular membrane, it makes sure that it stays balanced. Clear as mud, right? So then we've got the retinacular ligament. That there's two parts. There's a transverse and an oblique retinacular ligament. The oblique retinacular ligament is pretty important. It passes volar to the flexion and extension axis. So it's on the opposite side of the lateral band, and it links the motion of the PIP and the DIP. So if you sit here to yourself and try to move just your DIP, there's some folks that can do it, but most people cannot move those joints independently of each other. They're linked because of these structures. And I'll show you in a couple minutes why these structures are so important and what happens when they're all damaged. First, though, I want to show you something so cool. I had a patient a couple months ago that was treated for a completely unrelated wrist injury. And he was like, "Hey, is this normal? I can do this with my fingers." I was like, "What?" I've never been able to see someone's lateral band. So he can kind of pull himself into a swan neck positioning. So you can see very clearly the two lateral bands differentiating over the PIP and kind of popping out. So I just thought that was a nice image to see, like, where are the lateral bands? And you can see how proximally it's one tendon that splits into two parts and then it kind of starts to come back together. So I thought that was nerdy but cool. Okay, so here's a little bit more information about the retinacular ligaments and how the two joints are linked. So when the DIP gets flexed, what that does is it pulls the lateral bands closer towards the DIP. So it pulls it distally, and then that puts tension on the oblique retinacular ligament, so that ORL, which because of how it's connected is going to force the PIP to become flexed. So the PIP and the DIP are flexed together. The PIP can't be extended without the DIP because conversely, as the middle phalanx is extended, the oblique retinacular ligament gets stretched from there, which puts tension on the lateral bands, which causes extension of the distal phalanx. So basically, because of how they're linked, I think that top picture does a really nice job of showing how it's kind of swooping around from the volar side of one part of the digit to the dorsal side of the other part of the digit, and how the transverse retinacular ligament helps to link them together, but they're kind of working together to make sure that the lateral band stays in place, and the PIP and the DIP are intricately joined. So, we've talked a lot about the finger anatomy. Here's where it really comes into play, and here's why this stuff is important. So this first picture, this is called a boutonniere deformity. What that means is there's sustained flexion of the PIP with hyperextension of the DIP. A lot of times you'll also see MCP hyperextension. So what happens in a boutonniere injury is that the lateral bands fall volarly. So the lateral bands, instead of staying on the dorsal aspect, they slip and they become PIP flexors. But they're still attached to the dorsum of the DIP. So while they're flexing the PIP, they start to extend the DIP. So this can come from a lot of things. This can happen from a traumatic injury or from RA. A lot of the intervention for this is about splinting and maintaining everything in place, usually just with an extension splint for the PIP only for a couple weeks. Sometimes it comes to a surgical repair. Because this is focused primarily on splinting, we're not going to talk about the protocols and stuff too much here, but if you're interested, let me know and I will get you some more information. In this picture, we see the reverse. So boutonniere deformity, PIP flexion, DIP hyperextension. This is a swan neck deformity, hyperextension of the PIP with flexion of the DIP. So just like my patient was showing me earlier, on this patient here, you can see the lateral bands that have slid dorsally completely. So now they're becoming extensors of the PIP joint, but then, with everything else still attaching on the opposite sides, they're going to pull the DIP into flexion. So this is often really painful as things are snapping. Sometimes people can move out of this deformity and come into full flexion. Sometimes this becomes a fixed deformity. Just like the boutonniere deformity, there's a lot of different causes, maybe an extensor tendon rupture, maybe a ligament rupture causing increased lateral band mobility. This could be coming from intrinsic tightness. This can happen from even like a volar plate injury. So if the volar plate isn't able to maintain the PIP in flexion, it'll allow hyperextension and that can become fixed. So we would typically try to correct this with what's called an oval 8 ligament that I'll show you guys kind of towards the end of our lecture. The orthotic would allow full flexion but hold the PIP joint in a nice neutral extension. When you do that, even though it's just for one joint, it will balance the forces of the flexors and extensors. So correcting the PIP will also typically correct the DIP joint. This is another one that sometimes will require a surgical repair if it's really bad or if it becomes a fixed deformity. Sometimes it can be managed with therapy. So another injury that can happen to the soft tissues of the fingers, we're going to talk about a jersey finger. So a jersey finger is a zone 1 flexor tendon repair, which, like we talked about before, only the FDP tendon is involved there. It's often known as a jersey finger repair because it happens a lot with basketball and football players who reach out to grab the jersey of an opposite player, grab and twist as the other person is pulling away. So they're flexing against a lot of resistance and their finger is being pulled into extension by the jersey. But because the FDP is so strongly activated, it will snap away from the bone, which is just a tendon avulsion. The tendon with bony avulsion is where the tendon is pulling so hard, it pulls that chunk of the bone with it. So what you'll see is what this picture is showing here. You can get motion at the MCP, at the PIP, but there will be no motion at the DIP because if the FDP tendon is not intact, it's the only muscle that will bend the DIP. So if it's not there, there's nothing else to do that. It's the most common in the ring finger. I'm not entirely sure why, but for some reason it is. And this is an injury that will not heal on its own. If you see this, this is not, it has to be put back because the tendon will start to retract into the finger. Sometimes if it snaps really hard back, the vincula will also get snapped off and then the tendon can actually retract all the way down into the palm. Sometimes it might still be hanging out there, but either way, there's going to be force pulling it back proximally, so it won't be able to just heal to its same footprint. So what they do is they'll pin the tendon back onto the bone and immobilize for a little bit. I have had some patients though that, flexor tendon repairs are not an easy thing and outcomes aren't always great. So sometimes patients will choose, after talking to the surgeon about all the possible risks and what the rehab will be like, I have had some patients that chose not to get an operation and just say, you know what, if I can't flex that finger, fine, whatever. So if you try it on your own hand and you look, if your ring finger DIP can't bend, but the rest of your hand can make a fist, your hand is still going to be pretty functional and going to have pretty good grip strength. It can be pretty annoying to have a joint that's just kind of flopping around there, or it might get contracted in one position or another, but some people prefer that, and then they'll come to you just to work on strengthening, maybe edema control and protection of their hand during activities and stuff like that. On the reverse side, we talked earlier about the flexor tendon zones. Extensor tendon zones are different. It's the same basic principle where it starts distal and works proximal, and the reason that the zones are decided upon is because there's different anatomical structures. So we just talked about how there's lateral bands and ORL and all these different ligaments. Each zone in the extensor tendons indicates what structures will be involved. Extensor tendons, their naming method is it's I think a little easier to remember because the odd numbers are over joints. So 1 is over the DIP, 3 is over the PIP, 5 is over the MCP, so you know that the even numbers just go in between there. So we talked about a zone 1 flexor tendon repair. What would a zone 1 extensor tendon repair look like? So a zone 1 extensor tendon injury would be a rupture of the terminal tendon only. So everything else is working fine. That little bit of a tendon snaps off. So you get what's called an extensor lag at the DIP only. This, similar to a jersey finger, can be just the tendon avulsing off, or it can be a bony avulsion as well. The extensor tendon is nice though, because of the extensor head, there's so many other ligaments keeping it in place. It doesn't retract like a flexor tendon can. So if there's no bony involvement, all you have to do is make an orthotic to extend the DIP, and then because the tendon is still sitting right there, it can scar down and heal right back to the position that it was in. That sounds easy, but keeping your finger fully extended, no questions, for 24/7 for 6 to 8 weeks is really, really hard to do. So what I see a lot in my practice is people will be good for a couple weeks and then they're like, I think I'll be okay. Oh, I'm just going to take it off to wash my hands, or I'm just going to take it off while I'm in the shower or something. As soon as you start moving, that tiny little bit of scar tissue that's now trying to hold that extensor tendon back in place, it's going to snap and you have to start the process over from square one, 6 to 8 more weeks of it. Sometimes you might see people for one session though, just to make the splint, and then they can handle it on their own and they're good. A zone 5 extensor tendon injury is something that you'll see pretty commonly as well. It's a sagittal band injury. So remember, we talked about the sagittal band functioning to keep the EDC tendons centralized over the metacarpals. So you'll see this commonly in patients with rheumatoid arthritis. It can happen in all your fingers at once, like with RA, or it can happen just for isolated fingers with trauma or a laceration. So you'll see what's called an ulnar drift of the fingers, because if the sagittal band is not in place to keep the tendons centralized over the fingers, they'll slide to the ulnar side of the metacarpal, and then it'll pull the fingers in an ulnar direction. So it's kind of hard to use your hand very well. If it's one finger, and it's not that severe, you can treat with a relative motion orthotic. So it kind of looks like a yoke to keep, like an oxen cart. It yokes the fingers together to keep one relatively more extended than the other, because of the extensor tendon anatomy of the hand, when you go back to those earlier pictures of what it looked like, there's other structures joining the tendon. It's called the junctura tendineae. So the junctura tendineae are going to link the extensor tendons of the digits together a little bit more proximally than the sagittal band. So that's why you just need to keep it in relative extension to the others. That there are actually textbooks written about that, so we're not going to get into it too much, but just so you guys know, relative motion orthotics are out there and they are amazing. Okay, changing gears entirely. Now we're going to talk about fractures of the hand. So I would pause on this slide and take a couple minutes to look at different fracture patterns and, if it's the proximal versus the distal third, what's going to happen there, how does the bone tilt. This is a really nice chart to show because of the really complex anatomy of the soft tissues of the finger. What are the deforming forces on that bone when different areas of it are fractured? This I think is really important because it can tell you what deformities you'll see in the finger and give you an idea of what you need to do about that. So as the therapist, you want to know how the bone was fractured, where it was fractured, what kind of displacement, if there's any fixation, do they have to do surgery for it? There's a lot of different types of fixation. They can do pins, they can do plates, they can do screws, they can do bone grafts if needed, or you can go conservative with immobilization with a cast or orthosis, sometimes even without a closed reduction if it's really well in place. Like other fractures though, the earlier the motion tends to be better. There's some really nice research coming out about early protected motion that allows for what they're calling micromotion at the fracture site that can help stimulate blood flow to enhance fracture healing. So the earlier that you're moving, the better. So take a minute here and take a look at this chart. So this is another one that kind of talks about early healing for fractures and why early motion might be better. This also goes to show you that because of the way bone heals, like you have to know what's happening within the soft tissue structures. You can't just follow a protocol. It all depends on the stability of the bone. So you kind of want to mark on that very bottom of the chart, are we still in inflammatory phase? Do you see any hard callousing? Is there remodeling of the bone? Like what's going on? And that can tell you then on the top in those bars what kind of motion you're allowed to be doing. Can you do some resisted motion? Can you do just controlled protective motion? So, short range motion, like maybe half the range of motion. So in the note side, I'm not going to bore you guys and read this whole thing, but in the note side, you can see what all these, like, what is controlled protective reactivation? What is active protected reactivation? You can see what kind of activities would be allowed here. So I would spend some more time with this slide as well, because I think it would be a mistake to tell you, if you see this fracture, this is exactly what you do about it, because it's not entirely the way it works. This is going to serve you much better when you're in the clinic to get an idea of what is going to be safe to do. So we will talk about some fractures though. Metacarpal fractures are the most common hand fractures. I'm sure even a couple of you guys have probably had them and had some experience with them. They're really common in the ring finger and small finger. So you'll see them called boxer's fractures. It tends to be when people punch something. So the last one that I saw was, it was a law student. I want to say he was 25, and he got really mad at a basketball game, or he was at home, but he was watching a basketball game and his team was losing, so he decided to punch his wall, which had cinder block behind it, and he ended up with a 5th metacarpal fracture. The good news with metacarpal fractures, they tend to do awesome. They do really well, they heal really nicely. People will talk about things like, I don't have a knuckle. My knuckle disappeared. Well, you can still move your fingers, so you still have a knuckle. But what they're referring to is that the metacarpal head will be a lot less prominent. It kind of sinks into the hand. So that's okay as long as they can still use their hand functionally. So the stabilization really depends on the angulation and the displacement of the fracture. A lot of times they'll just do dorsal plating or pinning, and then again, get moving as soon as possible. In general, you can start active motion sometime within the first week, passive around 6 weeks, and then strengthening about 8. For conservative management, a lot of times, even, I put these recommendations for positioning on the slide, but those might change too. The wrist is usually in a little bit of extension. MCP is in about 70 degrees flexion, but what we're starting to see from a lot of our surgeons is they are letting the IPs free. So you can still even use your hand and move your fingers, you just can't move at the MCP joint. So phalanx fractures are a little bit more complicated. They're pretty unstable because of that first chart. I think it's slide 71 that goes over all the different deforming forces. But again, sorry to sound like a broken record, the trend is to go towards early motion. So this is a chart. I just wanted to, in this picture, demonstrate what kind of options are out there. Not that I expect you to know all of these, but what they're doing is allowing protected motion between certain joints only within a certain range. So in the first picture, they're allowing for PIP flexion, but keeping the DIP extended, stuff like that. So you'll see a lot of that out there. The most complications with phalangeal fractures is PIP flexion contractures. Those are really, really hard to repair. Distal phalanx fractures are often caused by crush injuries, so they heal pretty well. They're fairly stable, but they're really sensitive because you have a lot of nerve endings there, especially if they lose the nail. If they lose the nail, that can be a much longer rehab process and pretty painful, but if the nail falls off, it can come back, so don't worry. But it can just be really painful in the meantime, so you might want to provide them with like a Coban wrap or different silicone pads or something, just so that they can do things and work on desensitization, so that they're used to having pressure and different sensations, so that they're not avoiding and guarding their hand for everything that they do. Okay, so now we're going to move on to an evaluation. So thanks for sticking through all the anatomy and Knies review. And this, I hope, goes without saying during a recording lecture. Pause whenever you want, get up whenever you want, move. So this might be a good time to take a break. But otherwise, let's keep going. So the first thing that you want to focus on in any hand therapy, really in any therapy evaluation, let's be real, is your patient interview, because patients are going to tell you what's wrong. They don't know the right words, but they're going to guide you to the problem. I read a really interesting article recently that patients are interrupted every 11 seconds on average during a medical visit. They're coming in because they want to tell you what's going on. They want to talk about it. So I think it's really important to let them be heard. I think it's important to know, all the normal things that you guys know, to ask them about their past medical history, surgical history, comorbidities, have they had any therapy, and then also to ask, what's your expectation for therapy? Like, have you had therapy before and it didn't work? Because if they don't think that it's going to be worse, or if they don't think that it's going to work, it might not. So you might want to just have that discussion and see what they think is going to happen, and maybe they're not sure. Maybe they have no idea what's going on. So you just want to tell them like what to expect from you too. I think in hand therapy, it's also really important. People don't ask about sleep all the time, but if they're not sleeping, they're going to have a lot of other pain conditions and other things going on. So make sure you ask about sleep. And then something else you might not think about for other things is ask about hand dominance, because we use our hands in very different ways. I'm a really strong right hand dominant person. I can barely do anything with my left. It's only a stabilizer. So if I injure my right hand versus my left hand, I'm going to need very different things from my rehab on each hand. During your evaluation, we're all really big on outcome measures right now. So probably the most common one that you'll see in clinics lately is the Quick Dash. It's 11 questions that asks about different activities, and the patient rates themselves on how easy it is to do those things. I also really like the patient-related wrist evaluation. There's also a new modified version out there that asks specifically about wrist and hand. I think those can be a little bit more sensitive than something general like the Quick Dash, because if, the Quick Dash is for the arm and hand. So you can fill it out if you have a shoulder problem or if you have a PIP flexion contracture. So some of the questions on the Quick Dash might not be sensitive enough to capture the whole dysfunction, so you just want to make sure that you're using the right outcome measure. I think observation is super important. From the first time they walk in from the waiting room, you can see, how are they moving? Do they swing their arms back and forth as they walk? Did they use their hand to help take off their coat? Did they push up to stand? Did they carry their bag with that hand? Did they sign their forms? Are they keeping it guarded and protected against their hand the whole time? Did they shake your hand? All those kind of things can tell you a little bit about what's going on. Other things you can visually look for, see if there's any swelling or edema. There's any changes to the color of their skin or any trophic changes. Are they sweating a lot? That kind of stuff. How's their posture? Are they hunched over? Do they have horrible kyphosis? And and they're complaining of nerve issues, and you're like, there might be something more proximal going on. Are there any incisions or other scars? How are the arches? Or sometimes you'll hear it written as the attitude of the hand, which is the resting position, the arches and the normal muscle curves and muscle mass. So do you see any atrophy? And then the scaphoid tubercle check is the normal cascade of flexion. All the fingers should be pointing down towards the scaphoid. If when they flex their hand, not even necessarily during like a formal okay, I need to see you flex your hand, just as they're moving, most of us talk with our hands. So as they're moving, do their fingers point towards the scaphoid, or are they kind of going all wonky in different directions? You can also see some deformities that will tell you about what's going on. We mentioned the shoulder sign earlier. That's the dorsal-radial prominence caused by CMC subluxation with CMC arthritis. Wartenberg sign we mentioned briefly too. That's resting abduction of the small finger. So basically you try to bring your hand together and that small finger is always hanging out to the side. That will happen with an ulnar nerve palsy. With arthritis, either RA or OA, you might see something called Heberden's or Bouchard's nodes. Those are on the DIP and the PIP respectively, just these nodules caused by arthritis. You might have some ulnar drift going on. That's the resting position of the fingers in that sagittal band injury that we mentioned. Or even something called a dinner fork deformity. That's a malunion of a distal radius fracture. So full disclosure, I've never actually seen that in the clinic, but I wanted to give you guys these examples of things that before you talk to the patient, before you lay hands on them, before you even look at their chart, you can tell something about what's going on with their hand by these visual clues. I think it's also worth mentioning their nails and their nail health. So this is a really great chart. I would pause and spend a couple minutes reading through all of these different things. We're working in therapy with typically musculoskeletal injuries, but this is a great reminder that there's a lot of other things that you might be seeing. So typically, we're not going to be the one diagnosing, arsenic poisoning, like in Mee's lines. But I would spend some time looking at these and seeing what else could give you a clue about some of these other conditions. So you guys probably have gone over this a million times, but I just wanted to have it included so you had a complete list of what are normal ranges of motion. These you'll see different guidelines. So these are the guidelines through the American Society of Hand Therapists that I tend to use. But you can see even there's some question like, what is thumb radial deviation? Because we don't actually start from zero. The way that you measure deviation is you go based off the first metacarpal and the second metacarpal, and you put your axis on the trapezium. But you're not starting from zero. So how do you measure? What is normal then? I don't know. So a lot of it is observation. One thing that we do a lot in hand therapy that I haven't seen in other areas of practice, maybe it happens, but one thing we do is we calculate total active motion. So you'll see it written TAM, or total passive motion, TPM. Instead of looking at each individual joint of each finger, you would add the total active motion and say index finger at 200 and then compare to the other side instead of MCP at 84, PIP at 27. You can kind of total it and look, because that can give you a little bit more functional information. Now, this is something I think really important to know. Even though you just saw all the normal, typical ranges of motion, most activities don't need end range motion. So when you're making your goals, about 40 degrees flexion, extension, and a total arc of 40 between radial and ulnar deviation is usually sufficient. You will see different studies out there. You can use whatever things you want, but just know, you don't have to have an end range of 80 degrees supination to write all of your goals and to be functional in your daily life. So I don't typically write goals for the actual end range of motion because number one, it's going to vary person to person, but number two, we don't necessarily need that much. So you want them to be functional and pain-free. So you can use these to help as well. In OT school, we spend a lot of time talking about different grip and pinch positions. So forgive me if you guys also go over this a lot, but I think it's worth at least mentioning the different grip positions and patterns, because for different activities, you might need different positions, and these each use different muscle groups. So you can see there's a circular pattern like you're holding a ball, cylindrical like you're holding a tube that right now looks like an empty toilet paper tube, so very valuable. And then in that top picture, you can see the hook position. So like you're holding on to, I don't know, I guess that would be like the handle of the CTA bus, or like you're pulling open a door. Something like that would be a hook position. So something that you want to really look at is an activity analysis, depending on what activities they're having trouble with, and figure out what muscles do they need based on what position they're using. Power grasp, so when you're really holding tightly, that tends to come from the ulnar side of the hand. Prehension and dexterity come from more the radial side of the hand and wrist. So in our pinch patterns, then we're really looking at that radial side and we're looking at that dexterity. In the first picture, you'll see what is called sometimes 3-point pinch. Sometimes, I don't know where this name came from, but a 3-jaw chuck. I say 3-point pinch because you know exactly what that means. The lateral pinch is sort of the key position. So if you imagine yourself twisting a key in a doorknob, and then the palmar or tip pinch is just the pulp or the pad of your index and thumb together. These are just some of the basic ones. There's like 10,000 other positions. Like when you think about how do you hold your pen, it's none of these. But these are important things to look at and assess as well, to see what muscles are working, what's not, and what do you need to work on. During your assessment, it's also really important to look at sensation. The bigger picture here is looking at, this is the full Semmes-Weinstein sensory kit. You can also use 2-point discrimination and moving discrimination. Edema is really important to measure. You can use a tape measure, like for lymphedema treatments, and these are the typical landmarks that I use in the hand and wrist. You can also measure with something called a volumeter, which is what the picture below is showing. a volumeter measures the volume of water displaced when you put your hand in. So this is a really nice way to measure if you're like, oh my gosh, they're swelling all over. I can't measure all these different spots of every finger. It's going to take me the whole session. You can measure everything at once. It's just a little messy to set up and you can't do it with open wounds. So be careful with that, but it's good to know all your options. I use this chart a decent amount for patients that I'm suspecting have some kind of nerve dysfunction, where there's compression, but we don't really know why. Those really general hand numbness, and you're like, I don't know what's going on. So this chart breaks it up by peripheral nerve, a high or low injury. So I want you guys to spend some time reviewing your charts and see where does in this first example for the radial nerve, the extensor carpi radialis longus is innervated before the extensor pollicis longus. So what this chart is saying, if there's a high injury, both of those muscles are going to be weak. If there's a low radial nerve injury, the ECRL and the ECRB will likely be intact and have full strength. The EDC or the EPL might be weaker. Same thing for the median nerve. If you have compression up in your forearm, you might not have good function of your FCR or FDS muscle. But if you have a low median nerve injury, those muscles, because they're innervated higher up in the forearm, they'll likely be fine, but your thenar muscles will be impacted. So this really just follows pure anatomy and trying to use that anatomy to be a problem solver and figure out where the lesion is. So I test one high and one low muscle from each group if I'm trying to figure it out. When you're testing for nerve dysfunction, something else that can be really helpful is a test called Froment's sign. This looks for ulnar nerve function. So typically, the way the test works is you have the patient use that lat pinch that we just talked about. So they're using their adductor pollicis to squeeze a piece of paper between the side of their index finger and their thumb, and you try to pull the paper away. The adductor pollicis is a much stronger muscle, and it's a much better mechanical advantage in this position. So the adductor pollicis should kick in, and your thumb should stay flat. If the adductor pollicis is not working because your ulnar nerve isn't working, the FPL muscle, which is innervated by the median nerve, the FPL will try to kick in, and you'll get that compensatory flexion of the IP, which is what you're seeing here. Something else that you also want to really commonly test is grip and pinch strength. So back in the pictures of pinch positions, you could see that pinch gauge. This device is what's called a dynamometer. So this is the standard dynamometer I've seen at most of my clinics. There are 5 positions for the handles. We typically test in position 2. The smaller the space, the more intrinsic muscles you're using. So if it's really tight and it's very, like the handle space is very thin, you're primarily using your lumbricals. If you move it out to that all the way, the end part, and it's just like your PIPs and DIPs moving, that's all extrinsic muscles. So it depends on what you're looking for. Most people typically, though, are they're looking for gross grasp strength, which is a combination of both intrinsic and extrinsic muscles. So you test on position 2. The way that we test is you test each side 3 times, alternate between hands so one side doesn't get too tired, and then you take the average of the 3 trials. There are norms for grip strength based on age and gender and dominant versus non-dominant side. But to be totally honest, I stopped using the norms that much when I'm making my goals and things because the norms are decades old. I think they're older than I am by now. And the way that we use our hands has really changed. So I was finding that people's were wildly off. People weren't using computers then. People weren't using cell phones the same way. So our activities has changed the way we use our hands. So I think the norms can be used as a pretty general guideline, but just be careful to not use those as like, that's the end all be all. They must have this strength or they're not functional. I would compare to the unaffected side. Another thing that I wanted to talk about is how do we grade opposition? So opposition is the ability to bring our thumb over towards our pinky, right? The Kapandji opposition scale gives us a nice way to classify that and to grade it instead of saying like, they're short in opposition, they can't go all the way. People were coming up with all kinds of weird ways to describe it. Use the Kapandji scale, so then you can clearly communicate to other professionals how much opposition they have. Okay, so now we're going to get to some of the really exciting stuff with wrist evaluation. So the wrist is kind of divided into 5 evaluation zones, and what we're going to do is look at the structures within each zone, talk about how to palpate those, and some of the provocative testing. So first we're going to do the dorsal radial zone, so the back of our hand over the radius. What you'll find in this zone is the radial styloid, the scaphoid, trapezium, and the scaphotrapezial joint, the APL tendon, the EPB, APL, and the dorsal radial sensory nerve. So I'm just going to read these slides pretty much word for word since you can't actually see me doing it. We'll work on some of the palpation and provocative testing in lab though, so don't worry. So if you want to skip these slides, totally fine by me, or you can listen to me read them, whatever works best for you. So the radial styloid can be palpated on the radial aspect of the wrist proximal to the anatomic snuff box with the wrist in ulnar deviation. Pain at the radial styloid can indicate that there's contusion, fracture, radioscaphoid instability, and that would be common with an SL dissociation. Those are not the only things that are possible there, but those are some of the more likely things. To palpate the scaphoid, you go just distal to the radial styloid within the snuff box. And if you remember, the snuff box is formed by the EPL on the ulnar border and the EPB and the APL on the radial border. So the scaphoid is the floor of the snuff box. Pain at the scaphoid with palpation is indicative of scaphoid fracture, or non-union, or AVN, or instability. To palpate the trapezium, you trace down the base of the thumb, and while circumducting the thumb, that can help you palpate between the metacarpal and the trapezium. Pain at the trapezium can indicate CMC arthritis or ST arthritis, so scaphotrapezial arthritis. The first CMC joint, you palpate down the first metacarpal proximally to the base, and pain here can indicate arthritis, laxity, or instability. So within this zone, the provocative tests that you might want to do are the grind test, the what test, and Finkelstein's or Eickhoff's. So the grind test is axial compression with rotation of the first metacarpal on the CMC. A positive test would be pain and potentially crepitus, although that's not necessary. And what it's looking for is CMC arthritis. The what test is wrist hyperflexion and abduction of the thumb. You passively flex the wrist and abduct the thumb to the maximal range. A positive test would be pain, and this is positive for de Quervain's tenosynovitis. Finkelstein's and Eickhoff's are a bit of a mixed bag. The original paper was published a million years ago and did not have any diagrams or great descriptions of what the test was. So people have been doing them in a lot of different ways and just calling them all Finkelstein's or Eickhoff's. So typically what people call Finkelstein's is actually what Eickhoff later described. It's kind of confusing, but I just want you guys to be aware because you might see it in clinic more. Typically, it's passive radial deviation with the thumb flexed inside of the digits. This is a passive test. Positive would be pain, and again, that's for de Quervain's. Other conditions that you might see in this zone of the wrist are Wartenberg syndrome or Wartenberg's neuralgia that we talked about for irritation of the dorsal radial sensory nerve. You might see EPL tendinosis or what's called drummer's palsy, or intersection syndrome, which is irritation of the first and second dorsal compartments where they cross over. In the central dorsal zone, the structures that you'd find here are Lister's tubercle, the lunate, the SL interval, the capitate, the ECRL, the ECRB, the EDC, and the second and third CMC joints. To palpate Lisser's tubercle, this is a bony prominence over the dorsal distal end of the radius. So it's helpful to start by activating your EPL with your thumb and extension and trace that back proximally. Where the EPL takes a turn is where you'll find Lisser's tubercle. So this is a good landmark to find other structures, like the lunate, which is just distal and ulnar to Lisser's tubercle with the wrist inflection. Pain here could indicate Kienbock's disease or lunate AVN. The SL interval is found distal to Lisser's tubercle between the third and fourth extensor compartments. It's common to have dorsal wrist ganglions here, so that's why it's important to note. Pain here can indicate that there's an SL ligament injury or a ganglion. The capitate is found in a proximal direction over the dorsal surface of the third metacarpal until there's a small depression that's formed. It kind of forms a canyon in extension in a valley in flexion, is what the textbooks say. You can have a carpal boss near this area at the base of the second and third metacarpals. A carpal boss is a bony prominence at the base of the second and third metacarpals. In this area, some of the provocative tests would look at the scaphoid and the integrity of the scapholunate ligament. So the scaphoid shift test is also known as Watson's. You passively ulnarly deviate and slightly extend the wrist, and you as the examiner put your thumb over the scaphoid, then move the wrist radially into flexion with pressure on the scaphoid. When you let go, if there's instability, the scaphoid will clunk back into place because your thumb was holding it in place and it wasn't allowed to move the rest of the proximal carpal row. If the ligament is intact, it'll move and it'll go regardless of your thumb position, so you won't have that clunk. A positive test is pain or having that clunk, and that indicates SL instability. The scapholunate ballottement test is a shearing force on the scaphoid in a volar and dorsal direction. Pain and increased motion to the opposite side can indicate that there's SL instability. On the ulnar dorsal zone, you'll find the ulnar styloid, the ulnar head, the DRUJ, the TFCC, the hamate, the triquetrum, the LT interval, the fourth and fifth CMC joints, and the ECU. To palpate the ulnar head, you'd find the rounded prominence on the ulnar side of the wrist. So that one's pretty easy. The ulnar styloid, you have to find just ulnar and slightly distal to the ulnar head. Pain here can indicate an ulnar styloid fracture or non-union. The DRUJ is found radial to the ulnar head, so at the articulation point. Pain here can indicate DRUJ instability or arthritis. The TFCC can be palpated between the head of the ulna and the triquetrum within the ulnar fovea. Pain here can indicate TFCC instability. The base of the fourth and fifth CMC joints can be found by tracing the metacarpals proximally. The hamate can be palpated proximal to the base of the fourth and fifth metacarpals. Pain here can indicate a fracture or potential ulnar nerve involvement. The triquetrum can be palpated distal to the ulnar styloid within the ulnar snuff box. It's kind of in that interval between the FCU and the ECU tendons on the side aspect of the end. Pain here can indicate triquetral fracture or instability. The ECU tendon can be found in the gap between the ulnar styloid and the base of the fifth metacarpal, and it's most easy to find with the forearm in pronation and during active ulnar deviation because the tendon will activate. Pain here can indicate ECU tendinosis. There are quite a few provocative tests for this area. So we're going to start with the piano key test. This is an anterior and posterior glide in the extremes of pronation and supination. If the test is positive, the ulnar head sort of looks like a piano key when it's been pushed down and then you release and it pops back up. So the ulnar head springs back up. That is indicative of DRUJ instability. The ulnar fovea sign is when you press your thumb distally into the interval between the ulnar styloid process and the FCU tendon between the volar surface of the ulnar head and the pisiform. Pain here can indicate a fovea disruption of the distal radial ulnar ligaments or the ulnar triquetral ligament. TFCC load test is when you ulnarly deviate and axially load the wrist by moving it volarly and dorsally or by rotating the forearm. So pain here, or a positive test would be painful. You might have some like clinking or clunking or some crepitus. This can indicate ulnocarpal abutment or impingement or TFCC tears. The press test is when the seated patient pushes up from a chair using the affected wrist, which creates an axial ulnar load. A positive test would be pain that indicates a TFCC tear. The relocation test combines pronation and an anterior-posterior glide of the carpus on the ulna, which relocates the carpus into normal alignment. Positive would be relief of pain, unlike some of the other provocative tests, and this could indicate ulnocarpal instability or a TFCC disruption. The pisiform boost test is similar to the relocation test in that you're putting everything back in alignment, kind of where it should be. So positive test is relief of pain. So to perform this test, you dorsally direct pressure over the palmar aspect of the pisiform. So you kind of push the pisiform back into place. That lifts the carpus. This test is pretty vague. It just suggests ulnar involvement at the wrist. The mid-carpal shift test is the catch-up or clunk test, or sometimes you'll hear it called the pivot shift test. It's a palmarly directed load over the capitate and then ulnarly deviating the wrist with simultaneous axial load. This would result in a painful clunk as you're moving and indicate that there's some mid-carpal instability. The ballottement test, usually you specify if it's LT or ST, or SL rather. So this is the LT ballottement test that stabilizes the lunate and attempts to displace the triquetrum volarly and dorsally with the other hand. This will result in pain, clicking, or laxity and be indicative of LT instability. The shear test of LT instability is kind of similar to the ballottement test in that you stabilize the lunate and then you glide volarly and dorsally, so anterior-posterior for the pisotriquetral complex, which creates a shear force across the LT joint, and you can ulnarly and radially deviate the wrist while you're doing this. This will result in pain, clicking, and laxity in a wrist with LT instability. In the radial volar zone, you'll find the volar aspect of the scaphoid, the radial styloid, the volar aspect of the trapezium, the volar first CMC joint, FCR, palmaris longus, the median nerve, and the radial artery. So to palpate the radial styloid, you'll start at the base of the anatomic snuff box, palpate in a palmar direction to find its volar aspect. Pain here could indicate a distal radius fracture or radial carpal ligament injury. The scaphoid tuberosity can be found distal to the volar aspect of the distal radius at the base of the thenar crease. You would move the wrist from radial to ulnar deviation, and the scaphoid will push into your thumb. Be really gentle with this. You don't need to put a lot of force when you're palpating, because if you push too hard, you'll miss it. Pain here could indicate scaphoid fracture or AVN. The STT joint is found just distal to the scaphoid tuberosity, and pain here can indicate STT arthritis or volar wrist ganglion cyst. Provocative testing at this area largely looks at carpal tunnel syndrome. So Tinel's test can be performed over the median nerve at the carpal tunnel, where you tap over the nerve for 30 seconds to a minute, and pain and paresthesias in the median nerve distribution in the fingers would be positive of CTS. This Tinel's test can be performed for any peripheral nerve that's superficial enough. So you can do it over the ulnar nerve through Guillen's canal. You can do it for the radial nerve over the radial tunnel. You just want to indicate where the test was performed. Phelan's test involves sustained wrist flexion for 30 to 60 seconds by bringing the dorsum of the hands together. So you can stop once the symptoms are reproduced, though you don't have to keep going. Positive tests would be pain and paresthesias in the median nerve distribution in the fingers and indicate CTS. Allen's test, we went over that already, so we're not going to do that again. In the ulnar volar zone, you'll find the pisiform, the hook of the hamate, the FCU, and the ulnar nerve and ulnar artery. A pisiform can be found with the hand relaxed or in slight flexion, and you can kind of almost like pick it up and move it side to side. Pain here can indicate fracture or pisotriquetral arthritis. The hook of the hamate can be palpated by finding the hypothenar eminence radial and between 1 and 2 centimeters just distal to the pisiform. Pain here can indicate a hamate fracture or ulnar nerve irritation. Provocative testing would include the shear test, which is pushing or rocking the pisiform into or across the triquetrum. Positive test would be pain that indicates pisotriquetral arthritis. So in the next couple slides, we're going to talk about some other tests for the hand that you might want to look at to really figure out what's going on with your patient. So for the intrinsic tightness test, you hold the MCP joint in maximal extension, which stretches the intrinsics because what they want to do is flex the MCP, and then passively flex the PIP joint. Then you repeat the test doing the opposite. So now you put the MCP in flexion and passively flex the PIP joint again. If the PIP joint can passively be flexed more when the MCP joint is in flexion than when it's in extension, there's tightness of the intrinsics. So if the PIP joint can be flexed more when the intrinsic is relaxed, meaning the MCP joint is in flexion, that means the MCP joint is tight and limiting motion at both joints together. The oblique retinacular ligament test looks for ORL tightness. So what you do is hold the PIP joint in maximum extension and passively flex the DIP joint. Then you repeat the same thing, but with the PIP joint in flexion. If there's greater motion when the PIP joint is flexed than when it's extended, there's tightness of the ligament. So when the ORL is tight, it's not going to allow independent motion. To test for extrinsic tightness, so that's the long flexors and extensors of the fingers, passively flex the fingers with the wrist in extension, then repeat with wrist in flexion. There's less motion with the fingers and wrist flexed. There is extrinsic extensor tightness. To test for extrinsic flexor tightness, extend the fingers with the wrist first in flexion, then repeat with wrist in extension. There's less motion with the fingers and wrist extended. There's extrinsic flexor tightness. So now I'd like to talk about a few common hand therapy interventions. The goal of hand therapy, like most therapy, is to return to pain-free, as much as you can, normal and valued daily occupations, and to make sure that they can engage in their desired tasks. So typically we want to focus on function. So we've talked about some interventions already, and I think you guys are probably already experts in exercise. So we'll go over that briefly, but talk about some other things as well. First thing, activity modifications. We want to focus on educating our patients on safe positioning and ergonomics. So for example, we talked about our patients with carpal tunnel syndrome, have them typing with their wrist in neutral rather than sustained flexion. You want to educate people on using the appropriate equipment. So that can look like wearing appropriate protective padded gloves when pushing or hitting items repetitively with their palm. So this happens a lot with factory workers. You want to talk about joint protection techniques. You might want to teach one-handed ADLs while they're immobilized in a cast or in an orthotic. They can use built-up handles or use DISM, so it's like a non-slip surface to help open containers. And these are just a couple examples. What we really need to do is talk to the patient, figure out what things they're having trouble with, and then break it down and figure out what's going on that's making these hard, and see what kind of things can we do to help make those tasks easier. So these are some of the built-up handles that we talked about on the left. They just make it a little bit bigger so that instead of squeezing and holding really tight for fingers that are stiff or maybe weak, it makes the handle of something a little bigger so there's less strain on the joints. On the right is a button hook. It's about $8 from Walmart and is life-saving if you can only use one hand. This is just a nice quick little chart about ergonomics, about the position that you want to have everything be settled in when you're typing, and using a computer to avoid issues anywhere. I think it's really important too to make sure that you're looking proximally to see what else is going on with their neck, their upper back, their shoulder, their elbows, and not just talk about their hand and wrist. I think I'm also kind of a stinker on this. I don't like the rubber or gel wrist supports for keyboards because if you're resting on that, you're still putting pressure on the nerve. It's better to have the wrist in neutral and don't put pressure on anything. Just stop resting your hand. Just hold it up and make sure that your elbows are at the appropriate position, to make sure that your arm is supported there. So for common exercises, we already talked about tendon glides, so we'll skip over these for now, but because I love them, I wanted to put them in here again. Joint blocking is something unique to the digits that I think is kind of interesting because it encourages isolated joint or tendon motion with certain positions. So with blocking, what you do is you allow motion at only one joint at a time. So for DIP blocking, that would be picture C. You would hold over the middle phalanx and ask the patient to flex actively. So only the FDP is activated. In B, you can see the person is holding over the proximal phalanx, so only the PIP is moving. So that's primarily FDS is activating there. So depending on what motions or what muscles you want, it can be better to have specific exercises to target those. Reverse blocking is more for the extensor side of things. So you would hold the MCPs in flexion and put resistance on the proximal phalanx. That can be done with a therapist hand, or like in this picture, they can hold a pencil. So this is for the small finger. That pencil is holding the MCP in flexion, and you instruct the patient to try to extend their finger. What this is going to do is distribute all the extension forces through that complex extensor hood towards the DIP and the PIP to encourage extension there via the lateral bands. So you can have the patient do it like this with a pencil, or just with their other hand, or with a therapist hand. But this is a really important exercise in preventing PIP flexion contractures and decreasing any extension lag that you might see after various injuries. So we've talked about this a little bit already here and there, but proprioceptive training, or unconscious neuromuscular activation, is the buzzword that they're all using now. The goal with these exercises is to increase the dynamic stability in the wrist, increase the proprioceptive input, and encourage that unconscious neuromuscular activation. So basically, when they're not even thinking about it, can they move their wrist in the appropriate patterns? So we mentioned this but didn't see it before. This is the gyroscope. So within that yellow plastic circle, there's a weight, and when the weight spins, it'll start distributing the force outwards. So the goal with something like this is to keep that weight moving. The faster the weight moves, the more pressure is distributed outwards, so the more strength you have to use to keep it going. Your wrist has to have good proprioception to keep moving in a constant circle and be able to adjust its position based on minute changes in it. So I love using the gyroscope, but just be aware it does get up to, ours in the clinic gets up to 35 pounds resistance, so it gets pretty heavy. So this is not something you should necessarily do early on in your rehab. You can also use the body blade that's used a lot for shoulder rehab, and pretty similar to like the perturbations that you do for a lot of rotator cuff rehab. I also have seen a lot of really neat things about using cell phones to encourage unconscious neuromuscular activity. Basically, because when you're playing the game, you're absorbed in it and you're not paying attention to motions. So if they make games where you have to move your wrist more, they make games where you have to use your fingers, so you can decide what the patient wants to do and what game might be best for their particular injury. So on my phone, I downloaded a couple free ones. I really like Temple Run for fingers, Fruit Ninja for thumb, Paper Toss for fingers, Labyrinth is one for your whole wrist, Baby Bubbles is one for your finger, and Fall Down is for your wrist. They're free for iPhone. There's a lot of different types for Android too. I don't have an Android, but I'm sure there's a lot of things. And you just want to choose the games based on what goal you're looking for, but it's a great way to say, hey, do this exercise 5 minutes a day. All you have to do is play Fruit Ninja. People will probably do that. So sensory re-education or desensitization is really, really important to think about in the hand. We interact with the world by touching things and holding things, and sensation is a really important thing because after certain types of hand injuries, like after nerve injuries, you can either become hypersensitive and not be able to tolerate touching anything, which kind of renders your hand useless, or not be able to feel it and put yourself at risk. Cortical reorganization of the hand starts really quickly after an injury. There's been changes shown 10 days after a fingertip amputation, or for phantom limb pain, sometimes it starts within 24 hours. So you want to work to maintain that cortical representation of the hand, which means that you have to start exposing the hand to different types of sensory input pretty much immediately. You can also do this for certain types of scars to make sure they don't get hypersensitive as they're growing. Your goal is to use various textures, maybe vibration, maybe different temperatures, to stimulate and desensitize nerves to reduce that hypersensitivity or to encourage some sensory relearning. On the left is an example of a homemade sensory bucket. So for temperature, what you could do is take everything out except the rice and microwave that rice so it's nice and warm. You don't want it burning or anything, but the warm sensation will be really nice and relaxing. And we use rice because there's many small parts. So when you put your hand inside and the rice is moving, your sensory nerves are stimulated to tell your brain what position everything is and what's touching it. So you can use various different objects, like they have paper clips and a dice and a button and a nickel or quarter. I don't know what that is. So that you have to tell what the difference between the textures is. You can grade this by having the vision occluded first, so meaning you can't see it at all, so you really just have to rely on your sensory nerves. Or you can make it easier by having them look and say, you can't feel this because you just had a median nerve laceration, it's been repaired, but you know what this should feel like, right? You know what a penny should feel like. So feel it in your other hand, feel it in the other fingers, now feel it there. And your brain kind of starts to work to restore that sensation. So you want to start early in clinic in the rehab process, and then maybe give it as a home exercise plan. I usually get my patients do it 5 times for 5 minutes a day, and then keep checking in on it. But you don't necessarily have to devote every single session to it every time. On the right side is showing a kit. I want to say it's by Sammons Preston, that has it's usually 10 different, they call the sensory wands. They're different textures glued or pasted onto different pieces. So there's some that are really soft, like moleskin or cotton. And there's some that it gets up to pretty abrasive. So I think there's one that's actually, oh my gosh, I'm totally blanking. Sandpaper. Sorry, guys. There's one that's actually sandpaper that's really rough, and that feels terrible. So I don't really do that, but you can make a sensory wand really easily. We use tongue depressors in the clinic, and we'll stick anything that we have to it, like Velcro pieces or moleskin, and just use those soft textures to touch your hand, get it exposed to some kind of. So typically, sorry about the COVID, but we would typically bring a lot of this kind of stuff to lab and have you guys test it out and play with it. But I at least wanted you to see it so that when you go out in the clinic, you'll be familiar with some of these things. So, Theraputty, every hand therapist, both favorite and most hated thing. We use it all the time, but it gets everywhere. Theraputty is really nice because you can do whatever you want with it. So it's not a set thing. You can mold it, you can change it, you can use it for a lot of different types of tasks. Next to that is foam blocks. So this is nice when someone has a wound or is not quite strong enough for the Theraputty, but it comes in different graded resistance levels. The Power Web is nice. You can use that for a million things. Down in the bottom right are resistive clothespins. And then the bottom left is called the Digiflex. And most therapy things, for some reason, have a standard colored grading system. So yellow is usually the lightest, easiest resistance. Red or pink moves up a level, green, blue, and then finally black. So it's similar if you guys have used TheraBand before, but most of our things have resistance levels. So it's nice to know exactly how much resistance something has. So if you're trying to simulate an exact work task, you can say, you know what, I know that black clothespin is 10 pounds resistance, so we're going to practice turning the key in your truck to start it. And I know you can do 10 pounds. Okay, so one of my favorite things about being a hand therapist is making orthotics. So I know that most PT programs don't offer a hands-on orthotic fabrication section, but that's okay. I think in hand therapy, PTs bring a lot to the table. I think you guys get a lot more education on joint mechanics, joint mobilization, just the anatomy and kinesiology portion of hand therapy. And then I think on the other hand, OTs do a lot more orthotic fabrication, activity analysis, and modification. So I think that's where, again, hand therapy is a really nice merging of two different areas of practice. So really, though, no matter what your background is, hand therapy is a specialization when it comes down to it. So you're going to have to take a lot of continuing ed courses to learn a new skill. And I think orthotic fabrication is a really fun one, so don't be scared of it. So if you're interested in hand therapy, but like, oh no, I don't know how to make splints, that's okay. No one does that first. You'll figure it out. So what I want to do is just kind of introduce you guys to some basic principles of orthotics, because we've talked about them probably for almost every single condition, and I haven't really told you much about them. So orthotics can be fabricated in order to prevent or to support mobilization. Orthotics are often preferred because they're custom and can be designed to a patient's specific needs. They're preferred over the kind of store-bought ones. So a couple years ago, we were told by CMS, so that's Medicare basically, that we couldn't say splint or brace anymore because that doesn't imply skill in fabrication or fitting or anything like that. So anything that you buy from a store can be called a brace or a splint, but what we make or what we fabricate is an orthotic. So there's a lot of different kinds. There's static or static progressive, dynamic. So a static splint stays in the same position. Oh my gosh, I just said splint. A static orthotic stays in the same position. Static progressive is a firm end position, but you can remold it to change the position as you need. So maybe you want to get more elbow extension. So you'll start in whatever max elbow extension you can get, and then when they come back every week, keep remolding the orthotic so that they can get more and more extension every time. A dynamic orthotic works to regain motion through dynamic forces like rubber bands or elastic. These are not set rules. A lot of these different types might cross over, but the guiding principle of most orthotics is a low load, prolonged stretch. So you don't want to come and stretch absolutely as much as you can because they're not going to tolerate it really well, and that'll put that might cause some ischemic injury if you're stretching the blood supply to its max end position. So you want to just go low stretch for as long as possible. A lot of protective orthosis will allow for hygiene and maybe limited motion. So sometimes people like it better than casting. If you're wearing a cast, you can't take it off. If you're wearing an orthotic, you can at least take it off to wash your hand, even if you're not allowed to move. So basically, there's a lot of different kinds, a lot of different materials. As therapists, it's within our scope of practice to make an orthotic when it's necessary. We don't have to have a doctor's order, but I will tell you that some insurances won't pay for it unless you have the referral. So you might want to talk to your physician, but you don't need one. So there's a lot of orthotics that you can make for exercise purposes, not that they need to wear all the time, but you might just want to have a referral in the system just to get it paid for, but you don't need it. So I want to show you a couple examples of orthotic interventions for wrist rotation. So these are both immobilization. You have the Munster on top and the Sugar Tongue on the bottom. They're just different designs for the same thing. You could use these for TFCC repairs or tears, DRUJ instability, certain kind of fractures, like if it's a mid-shaft radius or ulnar fracture that you don't want rotation. And a lot of times they're used for lateral ulnar ligament repairs at the elbow as well, because you don't want to come into pronation, supination, either being stressing or straining the ligamentous repair. For wrist flexion extension, the basic is the wrist cock-up orthotic. This just shows that you can position it on the volar or dorsal side. You can use this for carpal tunnel syndrome, wrist fractures, or tendinopathies of the wrist. These are different versions of thumb spica orthotics. So there's the forearm-based or the hand-based, depending on what structures are involved. This could be used for patients with de Quervain's tenosynovitis, CMC arthritis, scaphoid fractures, or UCL or RCL tears of the thumb. These are some more orthotic interventions for fingers to encourage finger flexion. The first is the finger flexion strap. That's actually just a Velcro piece. You can even make it in the clinic, but you provide a slow stretch, and you can keep adjusting it to pull it further and further tighter, so sort of like a static progressive orthotic. The silver ring splint, that's also called an oval 8. Silver ring is more the company that it just indicates it's made out of metal. That will prevent hyperextension in the position that it's on of the PIP, but still allow for flexion. If you flip it backwards, so the kind of where the crossover is, you put that on the back of the PIP and have the two bands over the volar side of the proximal and middle phalanx, then it will prevent flexion, and that would be a really good splint to use for trigger finger. The last one is called a knuckle bender. So you can see that that is slowly pulling and pulling with those rubber band traction hooks on the bottom. That's pulling into finger flexion. So these can be used for tightness in the joints, such as you might find after dislocations or subluxations, different injuries with scarring, or finger fractures. On the other side of things, orthotics for finger extension, you might see just a basic volar gutter, an MCP extension orthotic, or an LMB dynamic extension splint. This we use really commonly. It's spring loaded, so you can see there's 3 points of pressure that slowly pull that PIP up. These you can use for joint contractures or stiffness due to fractures, tendon injuries, tendon adherence, scarring, or that MCP extension splint can be used for trigger finger. This is one of my patients. I just thought this was really fun. We were working on serial casting for PIP extension. So he comes in twice a week, and we put just a simple plaster cast on in maximal comfortable PIP extension. Change it twice a week, and we have been seeing about 10 to 15 degrees gains per session. So you just want to monitor for skin integrity. So it's kind of goes under orthotics. It's a cast, but used more like a static progressive orthotic. I just thought this was so fun because he had his kids decorate it for him. This is an example of an orthotic for protection. So this is called a resting hand orthotic that could be for any condition requiring rest and immobilization of the entire hand. Some fractures need it, some tendinopathies. some post-op conditions. The position is intrinsic plus, so that's slight wrist extension with MCP flexion to about 70, with the IPs in relaxed extension, so they're not like completely straight, but pretty much straight. The thumb is in functional opposition, so this maintains the collateral ligaments of the MCPs while preventing flexion contracture. I tend to make these a lot for patients with severe RA that just need a break. Their hands just hurt so bad. Or for patients after a CVA with flexor spasticity or really tight flexor tone. Something else you guys might see a lot, well, maybe not a lot unless you're working in hand therapy, but something you might hear about is a dorsal blocking orthosis that you would use for a flexor tendon repair. This is usually worn full-time, like 24/7 for 4 weeks after a flexor tendon repair. This is continued during the day as well for 6 weeks after, so an additional 2, but they can take it off for some exercises. So this allows the flexor tendons to be protected in the slack position while allowing for protected exercise. It's pretty much mandatory that people have some kind of protective orthosis. There's some debate over what kind for flexor tendons right now, but I mentioned it way earlier. This is one of those things where if you're not comfortable making an orthotic, or if you've never seen one, reach out to someone who has, because you don't want to be responsible for trying to take care of this patient and say, oh, your hand is weak, let me just do some exercises, because you need to be really, really protective of these types of repairs in these conditions. So a cool orthotic that I thought you guys might want to see is an orthotic to increase mobility. So this is a really good example of a dynamic orthotic where you can see clearly the rubber bands pulling the fingers in different positions while the base of the orthotic is maintaining the wrist in extension. So this is something we would use after an MCP arthroplasty, so a joint replacement of the MCP, which is really common in RA. So what this does is it allows a set amount of flexion, not that much, but it assists back into extension, and it pulls the fingers back into ulnar, into radial deviation to prevent that ulnar drift. Okay, so really quick, we're going to go over a little case study, and feel free to stop and pause. I put questions on here, not necessarily because I'm going to answer them, but things that I want you to think about. So we're going to go over a case study of someone that I've seen a couple times now. This time that I'm talking about is in this past October, so October 2019. He was a 69-year-old male that came to clinic with an order that just said right hand stiffness. So I want you to think about, if that's the order, you've never met this person before, what do you think the stiffness is coming from? What kind of deficits do you think you might see? What kind of things would you want to assess? What background questions do you want to know? So in the chart review, here's where we get a little bit more information. The hand surgeon's note said that he had a work accident. His hand was caught in a bread slicer over 20 years ago that left his left hand nearly severed. He had surgery at a hospital in Wisconsin, which means we don't have the records. And he told them that they took a nerve from my right hand, and his right hand hasn't worked the same since. So remember, he's here for right hand stiffness. There's also an EMG in the system that says it's an abnormal study, and you guys can see everything that's going on there, but bilateral C8 radiculopathies, right ulnar mononeuropathy with demyelinating changes, bilateral median neuropathy, left ulnar neuropathy. There's a lot of stuff going on. From the MRI report, you can see that there's pretty extensive damage or degenerative changes to his cervical spine as well. In May of 2019, he had a C3 through T2 posterior fusion because of his cervical myelopathy, and he had PT for a couple months to address his cervical spine deficits. And because of the problems they were seeing in his hand, the PT that he was seeing recommended that he go to hand therapy as well. So now after you know this information about him, what would you anticipate are his deficits? What do you think his hand might look like? What activities does he have a problem with? What things do you want to assess now? And what do you think his prognosis is? So this is our patient's hand. Proximally, we know that his C-spine is going to be limited because, he had PT, but he had a posterior fusion. He's still got some scapular weakness as well, but he was really good about doing his home exercises from the PT that he was still working on. So we didn't focus on that because we didn't want to have a duplication of services. But you can see from these pictures that there's atrophy between the metacarpals. So you can see how the extensor tendons are kind of pulling up a little bit, and you can see those grooves between, especially in the space between the thumb and the index finger. You can see where the first dorsal interossei should be. You can see that when he opens his hand, there's clawing of all the digits, not just the ulnar side. So he's got MCP hyperextension, IP flexion, indicating that he has non-functional lumbricals, which are median and ulnar nerve innervated across the hand. You can see hyperextension of the thumb MCP as well, indicating that there's poor thenar muscle function. You can see tenodesis when he opens his hand, so his wrist is flexed in order to extend his fingers. He does have full flexion though, which means that the FDS and the FTP and the FPL are functional. You can see he's got full MCP extension, indicating that the EDC and APL are functional. So on his evaluation, I measured his range of motion just to mark where his current status was, took a good history and profile, we did the quick dash, and we looked at sensation and measured his grip and pinch strength. So this is a video of what his hand looks like when you ask him to move. So I put the same things because in the note section, because I want you to be able to see as he's moving what those what the deficits and what the functional areas are. And you can replay that as many times as you need to. Hi everyone. Thanks for tuning in. My name is Megan. I am one of the occupational therapists in the outpatient care center over in 2C. Okay, so what in the world do you do for something like this? So what I did first is to fabricate an anti-claw orthotic to prevent contracture of the collateral ligaments at the MCPs. The benefit, in addition to preventing contracture, is it also brings his hands into a more functional position. So you can see when he tries to open his fingers, because the IPs stay clawed, he has a really hard time actually putting his hand around something to grasp it. So like grabbing a cup when your PIP and DIP stay flexed, try it. It's really hard. So what that does, by putting an anti-claw orthotic, it changes the force distribution throughout the fingers to allow the IPs to open a little bit more by bringing the MCPs into flexion. So his hand was a lot more functional just while using the orthotic. We also worked on doing a home exercise plan to make sure that he can maintain passive motion in that intrinsic plus position. So with the MCPs flexed and IPs extended, to make sure that he doesn't get contractures there as well. We talked about making sure that he was really good about doing his PT home exercise plan, where he was working on proximal neuromobility and cervical spine function. And to be totally honest, as an OT hand therapist, not my area of expertise, so I'm going to leave it up to the expert and just make sure he's still working on those and didn't have any questions about it. Otherwise, I would direct back to the PT who had previously seen him. Then one thing we worked on also is stabilization for wrist musculature, because he was having a lot of pain in his wrist when he was trying to use his hand. I think because he was overusing his wrist flexors because he was constantly coming into that tenodesis position. So we worked on a lot of stabilization to make sure that all wrist musculature was working well to hold his hand in a steady position. We also worked on some activity modification to have built-up handles for keys, using DICEM for non-slip surface to help open containers, trying to encourage that lat pinch instead of a 3-point pinch because his adductor was working pretty well. So it gave him a little bit more stability. So to be totally honest, I don't know what was wrong with his hand. There are both median and ulnar nerve problems there. I'm not sure, 20 plus years ago during a traumatic event, I don't know that they would have been doing nerve transfers, and I'm not a surgeon, but they don't typically do they don't typically take a healthy nerve out of a functional hand and put it into a partially amputated arm. So I'm not sure how this injury occurred, but I think there's partial traumatic injury, and then part of it was the wasting and the cervical compression too, which is why I wanted to emphasize to you guys that you should look proximal and distal. Because if I'm only looking at his hand before he had the fusion and no one else was looking at his C-spine, we're missing half the problem in the nerves. During his therapy session, we didn't want to work on intrinsic strengthening because he had 0 out of 5 MMT, and he's had this wasting and intrinsic weakness for over 20 years. It's likely that the motor end plates for the intrinsic muscles are non-functional, so trying to get him like, spread your fingers apart, bring them together, like that, he's not going to be able to do that, so we did not focus on that. Something else that we did not focus on is strengthening of the long flexors and extensors. So if we have him working on grip strength over and over and over, that would probably actually accentuate his clawing by making the flexors stronger. So we don't want to make those worse. So that's why I think it's really important to do a good evaluation and see what's there and what's not there. Because of the imbalance in his fingers, without intrinsics, if you just keep working on FDS, FDP, but there's no intrinsics to balance that out, it would just make his condition worse. And these are all the references. So we made it. Thanks for sticking with me, everybody. I hope this was really informative, and please, please, please don't hesitate to reach out if you have any questions or concerns. Hopefully when this thing is all said and done, we will see you guys back in clinic soon. And yeah, I hope you guys are interested in hand therapy and got something out of this lecture. And stay home, stay safe for now. Thanks, guys.